Good morning. I call this performance oversight hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, February 4th, 2026. The time is 9:32 a.m. Today marks the second part of the performance oversight hearing for the Department of Behavioral Health. We heard from public witnesses on Monday, and we thank those witnesses for taking the time. And today we'll hear from Dr. Bazaran, the Director of the Department of Behavioral Health, and her team. As I mentioned earlier, the Department of Behavioral Health, also referred to as DBH, provides prevention, intervention, and treatment services and supports for children, youth, and adults with mental and substance abuse disorders, including emergency psychiatric care and community-based outpatient and residential services. DBH serves eligible adults, children, and youth along with their families through a network of community-based providers and government services. DBH manages the district's school-based behavioral health program and operates St. Elizabeth's Hospital, the district's inpatient psychiatric facility. DBH serves district residents based on their belief that anyone can recover from mental and substance abuse disorders and live happy, healthy, and successful lives. On Monday, we heard from nearly 50 public witnesses, including community-based providers and contractors, community members, and advocates, who raised various concerns and also some praise. Those included some issues, however, with provider payments, limited engagement on the school-based behavioral health comprehensive plan, employee treatment, some gaps in services, and the need to improve accessibility. I don't see any of my colleagues at the moment, but certainly should any of them come, we'll welcome them with opening statement. Dr. Bazaran, you're here, so we'll turn to you. Before you begin, I would ask that you and anyone on your team who might speak today, got to swear you in. So if you're all raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
Yes, I do.
Great. All right, Dr. Bazaran, when you're ready.
Thank you, and good morning, Chairperson Henderson, committee members, and council staff. I'm Dr. Barbara J. Bazaran, Director of the Department of Behavioral Health. With me today are Dr. Megan Sullivan, Deputy Director of Child and Adolescent and Family Services, Michael Neff, our Chief Operating Officer, Mark Chastain, the CEO of St. Elizabeth's Hospital, and other members of my executive leadership team. Thank you for the opportunity to discuss DBH's performance in fiscal year FY 2025 and to date in FY 2026. Under the leadership of Mayor Bowser, DBH supports healthier, stronger communities by working to prevent the onset of mental health and substance use disorders and providing a range of community-based treatment services and recovery supports. DBH also provides crisis services, operates adult and child urgent care clinics, and manages St. Elizabeth's Hospital, the district's inpatient hospital. Through Mayor Bowser's continued investment, supported by the council, DBH is transforming the public behavioral health care system to provide whole person, culturally competent care for those who rely on it while working to advance health equity and address the behavioral health needs of all children and district residents. As we continue to transform the system with a whole person care framework during FY 25 and to date, our focus is standardizing quality care, strengthening oversight, addressing operational challenges, and ensuring that access to care keeps pace with demand. My testimony will provide a high-level summary of some of the major issues and challenges facing DBH and our progress in addressing them. I will talk about our work to strengthen the clinical platform across the provider network to ensure that the therapeutic needs of the consumers are addressed, identify improper billing and fraud, and impose penalties, including decertification, ensure network adequacy to meet the needs of residents and provide appropriate oversight to the provider network, lead the shift in how we provide school-based services so every student has access to behavioral health services, and address staff and operational challenges at St. Elizabeth's Hospital. I like to start with the basic question of whether residents are being served by the public behavioral health care system. In FY 25, a total of 53,058 individuals received at least one mental health or substance use disorder service. We're working closely with the Department of Healthcare Finance to track the impact of changes to Medicaid and Alliance eligibility levels on behavioral health coverage. DBH will align its eligibility criteria with DHCS. According to our records to date, 38 people have lost Medicaid benefits and 227 people have lost Alliance coverage. Providers were notified and are working with them to enroll them in available programs. If a person is receiving ACT services because of their greater vulnerabilities, we will continue those services using local dollars. We are committed to making behavioral health care services available to every district resident when needed. We are just as committed to making sure it's the right service that will lead to healthy outcomes. We are continuing our multi-year effort to strengthen our clinical platform across the provider network with targeted investments in clinical services by increasing the rate of clinical services, adding clinical care coordination with a higher payment rate to the service array, and establishing a universal assessment tool for adults to better match individuals to the appropriate level of care. We are monitoring the quality of care and compliance with evidence-based practice model standards for children and youth. Last fiscal year, 47% of youth served improved in at least one of 3 outcome indicators on the CAFAS assessment. We are continuing to implement policies to reform the use of community support services and most widely used service in the district and in the network to make sure that right people are getting the support they need. We are seeing good results. In FY25, there was an increased use of clinical services, including diagnostic assessment, therapy, medication management, and care coordination. There was an increase in care coordination from 5,720 to nearly 12,000, an increase of 48%. Providers are using the DLA-20 assessment tool to determine who can best benefit from community support. As we work together with our provider network, we expect to see increased use of the tool. To align with national standards, DBH is transferring the prior authorization of specialty services to Comagine Health, the DHCF's quality improvement organization, to ensure services are medically necessary, supported by appropriate levels of care documentation, and meet reimbursement requirements. The implementation of an authorization for community support services brought challenges as it took months to develop the process. This process places new administrative requirements on providers as they were required to request community support services for enrolled clients and submit the required documentation for approval. In addition, we identified that a significant minority of consumers had multiple transfers among providers in 1 year, and in some cases received community support service from more than one provider. This created challenges with tracking community support service and with payment issues for providers. We believe a process is now in place, but challenges still remain. We are preparing to launch a more clinically driven community support service in June, which will solve the administrative challenges. At the same time, we stepped up our auditing oversight of claims to identify irregularities in billing and fraud. The committee heard testimony from Deputy Mayor Turnish last week that the community support service benefit is rife with fraudulent claiming among a significant minority of providers. We know that improper billing often goes hand in hand with bad or improper care. Working with DHCF and the Office of the Inspector General, we are taking action to get bad providers out of the network. We have decertified 11 providers, of whom 5 are in the administrative appeal process before the Office of Administrative Appeals. In addition, we have suspended payment for 8 providers due to credible evidence of improper billing on the local payment side. DBH has ongoing discussions about the best way to ensure residents can receive services when needed and to provide appropriate oversight of providers. Today, there are 35 certified mental health providers, 16 substance use providers, 13 providers that are certified in both, and a total of 77 certified providers. DBH also certifies 21 freestanding mental health clinics. Today, there is a moratorium on new providers except for substance use disorder services and certain children's services where we want to increase availability while we assess adequacy. We also want to maintain elasticity in the system to accommodate the closure of providers. We are aware that some providers believe that our network has too many providers. We also take note that in FY24, the district's penetration rate is more than twice the national penetration rate as calculated by the Federal Substance Abuse and Mental Health Administration, or SAMHSA. Penetration rate refers to the number of people with identified behavioral health needs who get the services they need. In the district, 63.11 residents per 1,000 received a mental health service compared to 24.7 0.37 per 100,000 in the United States. Network adequacy means more than the number of providers. Last year, we moved to an online certification application to streamline the application process and eliminate the back and forth with documentation that extended the application process in many cases far longer than the regulations allowed. Network adequacy also means paying providers on time. I am aware that while providers have received Medicaid reimbursement, some have waited months for payments on local claims. At the start of FY26, the spending trend for community support created a projected budget deficit, and we froze funds for other services to address it. We have now prioritized expediting payment to providers, and I really apologize to those affected by the delay. We are moving forward with our plan to increase access to behavioral health services for all students in public and public charter schools. We are sad that Dr. Megan Sullivan, who leads this initiative, will be leaving DBH in the next week, but we are confident that she leaves a team in place that can continue the work. We thank her for her leadership. To make behavioral health services available to all students, DBH is shifting away from a one-size-fits-all model towards a diversified approach that includes multiple service delivery models. We will work with each school to adopt an approach that is tailored to their unique needs. I want to step back for a minute to the beginning of this process. I am aware that some of our partners did not feel that they were fully engaged in developing the plan. I also was not satisfied with our efforts, and we have continued to hold meetings and have listening sessions scheduled. We want to hear the challenges and make appropriate corrections, including how the first school year of the change will look. The committee recently held a roundtable devoted to the staffing and operational challenges at St. Elizabeth Hospital, where we outlined the progress we had made and our plan to continue to solve them. As we noted in the hearing, we are recruiting for all vacant nursing staff positions and other critical positions. Today, 3 behavioral health technicians, 4 nurses are on the onboarding process, along with 4 housekeepers. There are also 13 psychiatric nurses in the interview process. We have made funding the hospital's operations a priority, and we are systematically chipping away at the operational challenges. Now, I want to briefly update the committee on the district's fight to reduce opioid misuse and related deaths. DBH, along with about 100+ community and government partners, is encouraged by the continued double-digit decline in fatal overdoses, which is a 39% decrease from the prior year. However, there was a 33% increase in non-fatal overdoses during the same period. This indicates that we still have much work to do to connect individuals with services and supports. The good news is that there was an 11% increase last fiscal year in the number of people in medication-assisted treatment, which we know is critical to sustain recovery from this chronic disease. We are encouraged but staying focused on implementing through Live Long DC evidence-based and best practices in prevention, treatment, overdose prevention, and recovery supports proven to reduce opioid use, misuse, and related overdose deaths. With Mayor Bowser's direction and investment and the support of council, we are transforming behavioral health care in the district. Our vision is that all residents have the support they need to live healthier, longer, more fulfilled lives. I want to conclude my testimony by expressing my appreciation for certified peer specialists, leaders of consumer and recovery groups, and peer-led centers who model our conviction that treatment works and recovery is possible for everyone. Thank you, Chair Henderson, for your commitment to the health and well-being of all district residents. I am ready with my team to answer any questions.
Thank you, Dr. Bazaran. We've been joined by Councilmember Wendell Felder from Ward 7. Councilmember Felder, do you have an opening statement that you wanted to make?
Yes, thank you, Madam Chairperson. Good morning, everyone. Thank you, Chairperson Henderson, for convening this morning's hearing on this important discussion. Thank you, Dr. Bazran, for joining us this morning. The Department of Behavioral Health supports some of our most vulnerable residents here in the district, including adults and children living with mental health issues and substance disorders with prevention, treatment, resiliency, and recovery efforts. DBH is doing some great work for our community, including youth treatment opportunities, opening a new clinic in Ward 8 at the ARC, and hiring 2 full-time peer recovery support specialists. Furthermore, 86% of beneficiaries ages 6 through 17 receive clinical follow-up within 30 days of being discharged, and this is commendable. However, there's still many areas for improvement. I can see that in FY 2025, only 50% of patients reported satisfaction with DBH's facilities, and only 59% of targeted schools had behavioral health providers, falling short of the goal of 70%. Additionally, the average time for 911 calls to community response team arrivals on scene for priority one calls is 91 minutes. And just a few years ago in FY 2022, the Metropolitan Police Department responded to over 36,000 behavioral health calls, while DBH's CRT responded to fewer than 6,000. This imbalance continues to be subject individuals in mental health crisis to unnecessary trauma, hospitalization, and criminalization. For Ward 7 residents specifically, the community response team was dispatched 482 times in FY 2025 and 94 times in FY 2026 to date. As the Ward 7 council member, I have a vetted interest in improving these rates. It is clear that the district's behavioral health crisis response system remains critically under-resourced and over-reliant on law enforcement. And as a result, we fail to meet the needs of those individuals in crisis, particularly our youth. Now, I look forward to hearing more today about the steps DBH is taking to meet its goals across school-based behavioral health coverage, crisis response time, and how the council can be supportive with achieving those efforts. Thank you, Chairperson.
Thank you, Councilmember Felder. Okay, so we are going to, sorry, there's this, I didn't know this was a touch-based screen that is in front of me, but it is. Okay, Councilmember Felder, we're going to do 10-minute rounds. There'll probably be other council members who will join. I think there's some other hearings that are going on today. Dr. Bazran, I wanted to start our conversation today about grants. So on Monday, we had some public witnesses who raised concerns about grant-related challenges, particularly the need for providers to rely on local dollars to support mental health rehabilitative services, so MHRS. The committee has received reports about outstanding provider payments from FY 22 and FY 23, which is obviously very concerning considering we're in FY 26. Are there ongoing issues affecting timely payment for grant funds in MHRS right now?
Yes, and Michael Neff, our COO, can speak more to this. But certainly, we have looked into the grant payments.
Okay.
And ensuring that particularly the providers who have grants for local-only services have received their grant documentation so that they can bill. The other thing that I think will be helpful is we do have plans to move forward with a new grants management system. And that will help us track our grants and will kind of speed up the process. And so I'll have Mr. Neff respond a little more to that.
Okay. I mean, Mr. Neff, Hillcrest Children Family Center said they haven't been paid since September. It's February.
Correct. So I'd like to go back a little bit. Local payments are not grants.
Okay,
They're local funds used
Mhm.
to fund human care agreements, which are contracts,
Mhm.
not grants.
okay,
So we experienced a potential deficit, significant one, due to increased cost primarily for community support and RSS. In order to cover that, we had to look at how we prioritize our funding. To date, we have on the MHRS side, all but one provider who has a PO, which should be
Mhm.
done today. And, and I'm in regular communication with them. If you, the local funds, were prioritized. For example, um, providers don't spend or may have a larger portion that they rely on for local funds. And that would be substance use residential treatment for room and board, which is always local payment.
Mhm.
And the second group would be providers who treat larger immigrant or alliance populations, and that would be Neighbors Consejo or La Clinica. And so since beginning 10/1, all of those groups have had purchase orders. But
okay, but a purchase order doesn't mean payment.
um, a purchase order does mean payment. They've not had purchase orders.
They have to bill.
You have to bill. It's not you claim.
No, I understand. What I'm saying is, just because I have a purchase order doesn't mean that I have money in my bank account yet, which is accurate.
Right.
Okay.
But let me,
What I'm saying is providers are saying they've been billing since 10/1
Right.
and they have yet to receive any payment since.
because they don't have purchase orders. It's not like DHCF processes claims. The
Okay,
local payments have to be supported by a purchase order in order to be paid. So you submit the claims and that batch claim becomes an invoice submitted through the PASS system for payment.
so why do we have providers who are providing services without having a PO? Because that feels like they just are donating their time. But I have to imagine that they might have had some conversation with someone at the agency who suggested that they should continue to provide services, no?
Well, they've got a continuation letter from the OCP to continue services through end of November
End of November, which year? This year, 26?
for fiscal year 26. So it'd be November of 25.
No, but we're in 26. We're in fiscal year 26. So if they received a continuation letter, what would the continuation letter have been through? Only for 1 month?
2 months.
So they're, okay,
October and November was the continuation letter period.
okay. So let me ask it a different way. How many providers who had POs in FY25 don't currently have a PO for FY26?
On the MHRS side, 1 and 3 on the SUD side, and those are being put in the system.
Okay, so when should they anticipate payment or a
We've
PO?
already, the claims have already been processed. There's multiple transactions that happened. So if they've submitted weekly claims, we process them. We've not been able to warrant or pay them because they lacked a purchase order. That's the funding mechanism to a human care agreement.
Okay, is it common practice for us to have providers provide services without having a purchase order?
It is not.
So what happened here?
We were planning on figuring out how to cover a deficit because of needing to provide the same, not the same, local funds to cover Medicaid match.
Okay. How much, I wasn't planning to go there yet, but what is the current budget pressure for Department of Behavioral Health
For
for FY26?
25 million.
25 million. And that is Mainly due to CSS and RSS?
Correct.
Okay. Okay, so those are contracts. On the grant side, we have had grantees who have reported that their opioid abatement settlement grant payments, which I know are grants, not contracts, have not yet been issued. Are there some delay issues in the execution of the notice of grant awards for the opioid abatement grants?
For opioid abatement grants,
Mhm.
one of the things that I do want to share around the opioid abatement grants is that someone will get a letter indicating they have a grant, but then we have to finalize that process. You have to, for example, make sure that the budget is appropriate for the services that they're going to deliver. And so there's some back and forth between the actual provider and our staff. And one of the things that I can tell you is that it does take some time to do that. And that does delay the process of getting that money to them because you got to have a fully executed agreement before that happens.
Right.
So I could get a grant in
You can get a notice of
I
grant
notice a
award.
grant award, and my actual grant execution is, a way away from that. And so I think that's a piece of it.
Okay,
The other piece is that we are overall improving our grant-making process, period, by doing some of the work that Mr. Neff has in play to have an electronic grants management system.
okay. I wasn't gonna ask this yet, but I'll ask that now. So
Okay.
a year ago, we talked about this electronic
That's right.
system. What's the status? Because a year ago, you guys said September of 25, it would be done.
We did. Yeah, absolutely true. So we had to reprogram funds.
Okay,
And we do have an executed MOU with DC Health.
Mhm.
We are actually purchasing their grants management system. Right now, we have begun the process of setting up the project and funding it. In that process, it's a back and forth within the DIF system, takes a couple of weeks. At that point, we will have a kickoff, and we have trained staff that are trained in setting up the Salesforce system. And they will begin the process of getting ready to transfer that system to DBH. And then they will do a training for us, and we will migrate the data, which should happen end of April and May. And then there's a period where we have the technical staff working with us to do any type of augmentation of the system. Yeah, we may find that we need to change some forms to comply with federal, statute changes.
so July?
We'll have a system that will have our data in May,
Okay,
but we may need to do some things to make it change to comply with changes in the federal system.
okay. Thank you. Councilmember Felder?
Thank you, Madam Chairperson. Director Bazron, in my opening statement, I talked about the importance of crisis response. In FY 2025, you guys exceeded the targeted time for crisis response. And my question is, could you speak to what steps are being taken to reduce crisis response times?
Yes, first of all, I would like to share that we have a new chief of
Mm-hmm.
crisis services,
Okay.
Ms. Jana Burhow, who is here with us today, who can give you some of the more granular information around crisis systems. But she is currently in the process of really upgrading our system. That includes hiring more people for our CRT teams.
Mhm.
It also includes looking at the full continuum of services that we have in terms of our crisis response system. So we're working very hard to do that and very diligently. The other thing I'd like to share is we do have 5 staff that are co-located at 911. And
Mhm.
we've been working closely with the director to make sure that as many calls as possible are diverted from MPD to
Mhm.
our team so that they can get a non-police response, but rather a clinical response. And a part of that is looking at what the protocols are and how we might be able to really look at the protocols so that we can get more of a response. So that's kind of where we are. We have a lot of work that we're doing in this area, and I think that we will exceed where we were before.
Well, just to follow up, you didn't quite answer my question, so I'm
Okay.
assuming because so you have a new crisis response manager. I'm assuming the old one, you guys made some changes. Uh, I'm still trying to figure out what steps are in place to reduce the crisis response time.
Why doesn't she come up?
Yes, come on up.
Okay. Councilmember Felder, we're gonna pause your time. They're gonna phone
Yes,
her.
ma'am.
Hold
Thank
on.
you.
Yep.
By hiring more staff is one thing.
Okay, gotcha. Okay.
That's a biggie.
Okay. If you just introduce yourself for the record.
Good morning. I'm Jana
Good
Burhow, Interim Chief of Crisis Services for the Department of Behavioral Health.
morning.
Good morning. Yes, Councilmember Felder. We're in the process right now of looking, like Dr. Bazran said, at a variety of ways to reduce the response times, including staffing up the program
Okay.
with both the supervisory staff and the direct line staff that's needed to respond in our community. I'm also doing some geomapping with OUC and with FEMS around the locations in the district around where we have the highest calls and the highest response for what those two agencies call mental health cards or mental health responses. We're looking with OUC, right now we're in the middle of analyzing some information from the month of November that are calls that were 911 calls that were mental health cards, if you will, designated as mental health, that did not come to DBH, to see if we can clinically review those and see which of those calls do we think DBH actually could have taken. And once we're finished with that analysis, we'll work with OUC, MPD, and FEMS to see, like Dr. Bazran was saying, in the protocols, how can we adjust those so that we're taking more of those calls?
Okay.
Also interested in doing that with FEMS. Had kind of a data conversation with FEMS recently as well around kind of doing that same exercise around calls that FEMS might be taking that are labeled as mental health calls that maybe would be more appropriate for CRT so that we can really get into those weeds and see
Okay.
how we can better respond. But to your specific question about response time, some of that's about co-location as well.
Right.
You know, our location is at Howard Road. We have some co-location in a bid. But I think we need more co-location
Okay.
of response launch pads, if you will,
Right.
into our community so that we can reduce the amount of time from call to person on site.
Okay. Thank you. And once you guys make these improvements, how are residents being notified? Or like if you're hitting your goals?
Well, I think that first of all, in terms of the resident response, if someone calls 988 or calls our CRT, someone will immediately address their needs and talk through what the issue is, and a determination will be made whether or not somebody needs to be deployed. So the information in terms of how to get services will not change. However, we will be able to get there faster as we implement some of the changes that Jana has talked about.
Thank you. Now, Director, I saw that DBH did not meet its school-based behavioral health coverage plan.
Mhm.
Could you share what do you think that was attributed to?
Yes, we're going to, just give us a moment here.
Okay.
Dr. Sullivan is our Director of Child, Youth, and Family Services, and she and her team, under my leadership, have been actively involved and have developed a plan. And so I'm going to give over to her to answer some specific questions.
So you're absolutely right. I think you mentioned that last year we were about 58% was our
Mhm.
percentage for a number of clinicians providing services in the 250, last year 254, this year 253 DC public charter schools. So over the last several months and this summer, we spent a lot of time creating the comprehensive plan and have been
Mhm.
working with our partners and implementing some of that. And so where we are today is we're really changing that focus. I think you're well aware that in the past, it was really a one size fits all approach. And so it was one licensed clinician in every school. And so through work with our coordinating council members, lots of partnerships and meetings, we really shifted that, we're shifting that thinking from one size fits alls to making sure that we provide what the school actually needs. So our resources will look different. In that, we're also shifting the types of clinicians that are in the buildings. And so where we're at today is we're at about 77%.
Mhm.
And the way that we've shifted that is we are still in a hybrid model where we have CBO clinicians that
Mhm.
are providing services in about 116 schools. We also have DBH clinicians continuing, DBH hired clinicians, sorry, who continue to provide services in about 59 schools. We have a few specific LEAs in schools that receive the same amount of funding to also hire clinicians. And then
Mhm.
so we've increased, right? And so we know that over the years that number's kind of gone up and down, but we really feel confident that moving forward with this new kind of diversified approach has helped us get into more schools and, as Dr. Bazran mentioned, provide access
Mhm.
to all the students.
Copy. Okay. Uh, Director, could you speak to how DBH is ensuring that our youth and families can access service without long wait times?
Can access services without, I'm sorry,
L- Long wait times.
without long wait times.
Yes.
First of all, here again, there are several ways in which they can access service. They can walk immediately into one of our core service agencies and receive services immediately. They can walk into 35 K Street where we have our clinic and receive services, or they can call our Access Helpline and get information regarding service availability and be connected to care. So there are multiple ways in which they can connect to services fairly quickly.
Got you. And how are you measuring whether substance use treatment, or rather, how are you measuring whether the substance use treatment expansions are leading to a reduction in overdoses or hospitalizations?
First of all, we do have a fairly comprehensive dashboard where
Mm-hmm.
we do collect information in terms of both fatal and non-fatal overdoses to see whether or not we are making progress. And what we have learned, as I said in my opening remarks, we have seen a significant decrease in fatal overdoses. However, we still have a lot of work to do in terms of non-fatal overdoses because we've actually seen an increase there. The other thing we have done and we are tracking is how many people are people in service and in care. And we know over 5,000 people are in service. How many people are in medication-assisted treatment? But because we know that that works. And so we track that over time also. And then the other thing that we have spent time on over this past year is expanding the services that are available for young people, for transition age youth in particular. And we have done that in partnership with Children's Hospital. As you know, they have expanded a clinic in Ward 8. And also, they have opened and expanded their outpatient treatment services for youth. We also have, for the first time, a residential treatment facility for young people. And so I think all of those factors are what we look at in terms of what is the continuum of services we need, and then how many people are accessing those services, and then what are the results? Are we making a difference? And we're seeing that we are, but we still have to double down on the non-fatal issues.
Thank you, Director. I see I'm over my time. Madam Chairperson.
Thank you, Councilmember Felder. I would say this for staff who may be listening. If your bosses are planning to join, and if there's not another council member who is here, just let my staff know, and I'm happy to stop, so they don't have to wait an additional, 10 minutes or whatnot in order for them to join. Okay, Dr. Bazaran, I want to go back to talking, I guess, some budget questions, but also from an oversight perspective as well. So DBH transitioned authorization of several specialty behavioral health services to Department of Healthcare Finances Quality Improvement Organization. They contract with CoImagine. This started in the beginning of February of 2025. How is DBH retaining real-time visibility and accountability over utilization and spending now that some of these functions sit with healthcare finance?
Well, yes, CoImagine is at this time providing authorization. Well, it's actually for for several of our services. One are crisis beds. The other service that they are looking at right now is we have crisis beds and also community support services. And we get feeds from the Department of Healthcare Finance that gives us information on on where we are in terms of the spend rate, the utilization rate, and so forth.
Okay, so what does DBH's authority begin and sort of end?
Well, our authority begins a couple of places. One, we have actually developed the requirements for service delivery,
Okay,
and I think that is really important.
yeah, okay. So do you all jointly establish the review standards and documentation standards?
Correct.
All right, so who is ultimately accountable if inappropriate billing or service delivery goes undetected?
Well, we actually work together on that. We meet regularly with DBH's, with DHCF's team, looking at inappropriate billing and fraud,
Okay.
waste and abuse. And actually, I'm going to have my senior deputy come up, who has been intimately involved in those and is responsible in that.
Okay, I'm going to just hang on just a second, because I want to ask sort of a question about this. So in our hearing last week with healthcare finance,
Right.
we spent actually a lot of time talking about
Mhm.
quality review, billing, and fraud, because ultimately not only are patients not getting the services that they need, but it's also costing the city a lot of money. And one of the things that their chief of integrity over there said, so I asked a question about provider payment suspension spiking in FY25. And they said, yes, they had 15 providers who they had to suspend. Cumulatively, that was $124 million that were billed amongst those 15, and they were all behavioral health. So then I have to ask the question, okay, then when we look a little further at it, it's really coming out of two places: recovery support
That's right.
and community support, which by definition in theory are very similar.
Very similar.
Now on one, we did put a limit on the number of units on CSS, but we didn't do that with SUD recovery support services.
That's correct.
Why didn't we do it at the same time?
We actually sent a team out to do an unscheduled visit on the two providers that were the ones that where we saw the spike in utilization and cost. In one instance, we found that there were issues, and we took action against that one. And I believe did we decertify them? Yeah.
If you just want to introduce your,
Yes.
well, please introduce
The
yourself.
other thing with the other provider, we found that when we did a review of the actual records, we found that in fact they were delivering that service. But they just had a lot of people that they were serving. So in one instance, we found that there were fraudulent activities and we had to take action against them. In the other situation, we found that they were actually providing services.
Good morning. My name is Atia Jackson. I'm the Senior Deputy Director at the Department of Behavioral Health. The question that you originally posed was around why DBH did not impose limits on RSS at the same time as we imposed on CSS.
Yep.
We did not impose those limits at the same time because we wanted to be thoughtful and not have to do it multiple times. If you may recall, but I know our providers recall, there were multiple iterations of the limits on community support services.
Right.
And that's challenging for providers when they're developing budgets, when the max amount of units that are allowed goes back and forth. So we wanted to learn from that past experience and be more thoughtful with RSS. In the meantime, the Department of Healthcare Finance did put a higher cap on RSS. They have a routine report where they look at an individual rendering practitioner that bills more than, I think it's like 16 hours per day, and they folded RSS into that report so we could capture some of that. And Dr. Bazran is absolutely correct. We put boots on the ground with our partners at DHCF immediately at these two providers, in addition to suspending payments. And those investigation and audits are still in play, and we'll have more to come from that.
Okay. I feel like in some cases when we have bad actors, it's like whack-a-mole, right? So, okay, I can't do community support anymore because they figured that out. Let me hop over to RSS.
That's correct.
Until that happens, et cetera. So to what extent are you all reviewing all of the services that can be billed for to see what's the next hop to? Because they're all so similar. And can we not take an evaluation and look at it all together?
Well, first of all, we do look at the data on a routine basis with the executive team. We look at what the utilization is and what the costs are. And when we see spikes, then we work very closely with DHCF to determine whether or not there's fraud, waste, and abuse. When we saw the spike in RSS, we moved in on that one fairly quickly. And as you said before, RSS and community support are very similar. One is for mental health and the other one focuses on SUD. So those are very similar services. But we are really tracking over time. Those are two services that are very similar, but we're looking across the board.
So if I'm a patient that has co-occurring,
Sure.
I've got SUD going on, I also have mental health going on, can my provider bill for both CSS and RSS? Because that seems like a double dip.
Yes.
Your provider has to be certified for each
To do both.
service. Not all providers are.
I know,
When
but
you-
for the ones that are certified SUD and mental health,
That's on our radar. That's going to
okay,
be the next
Right.
step
okay.
of regulatory.
The answer is yes, they can, but here again, we are observing that very closely.
Okay. Is there another form of community support like,
No.
No.
No,
You've
service.
identified those two.
okay,
Because when you look at our continuum of services, RSS and CSS are the ones that can be delivered by unlicensed staff.
Right.
The continuum for SUD and mental health don't have other services that can't be delivered without a clinician. So in the big scheme of things, the pool of unlicensed workers
Yeah.
is broader than the pool of clinicians. And there's a role for that, right? There's
Yes,
a role for
sure.
paraprofessionals to support the clinicians in the delivery of behavioral health care to the public.
And I think that there's certainly a role for that. I think that I think people are able to draw the distinction between someone who's providing a service as a licensed clinician versus someone who is providing, and from a community health worker standpoint. And just for the public to understand why I'm harping on this, during a 6-month period in fiscal year 25, Medicaid billing for SUD recovery support services increased by approximately $17 million in 6 months. When we had been only billing $3 million annually. So somebody found a little, I'm not going to call it a cash cow situation, but they found a cash cow situation. And then we're going to go through the process on that. But I just want to make sure that next year we're not going to have a new spike.
No.
Yeah, and as you mentioned and the director mentioned, we looked at that data and the public needs to know that's not the service delivery method for the entire SUD provider network.
Right.
That was driven by 2 providers who we are on top of right now.
Okay, and I'm going to ask some follow-up over that, but I'm over my time. Councilmember Felder, did you have some additional questions? Did you change clothes?
He changed his clothes.
Sorry, you're on mute, Councilmember Felder.
Great observation, Chairwoman. Yes, I did. Nonetheless, picking up where I left off, Director, could you speak to what steps are being taken to improve continuity of care after discharge from hospitals and stabilization centers?
Yes, I can. We actually have an integrated care coordination function within the Department of Behavioral Health. And there are staff who meet with the team before someone is discharged
Okay.
to make sure that they are connected to those services within the community in a timely fashion. And so that care coordination is very, very important. We also have within our framework clinical care coordination where the clinician that's involved with that person, that individual who may be in the hospital or in a PRTF can also work to connect them to the care that they need.
Copy. Now I'm gonna shift my questions to more Ward 7 focused questions. So, Director, as you are aware, Ward 7 represents a significant share of crisis and youth service users. Could you speak to what targeted investments are being made in Ward 7 to meet this demand?
Can you say that again, please, sir?
As you are aware, Ward 7 represents a significant share of crisis and youth service users. Could you speak specifically to what targeted investments are being made in Ward 7 to meet this demand?
I think in Ward 7, we do have a variety of services that meet the demand. One is certainly we have school-based behavioral health, which meets that demand. We also, here again, as Ms. Burhow was saying earlier, we have a CRT and other support services which can be deployed to address crisis among your community members. And we're looking here again at how we might be able to have launch pads within areas like yours so that we can even get there quicker than we can right now.
And Director, you talked about launch pads. Could you speak to what who is DBH working with within the community, specifically community providers in Ward 7, to expand access to care?
Well, we've been working with not only the individuals in the business improvement districts, but also looking at things like we have prevention centers located in our wards throughout the community. And
Mhm.
also, we're looking at other potential locations. And so I don't have specifics on Ward 7, but I can
Okay.
get that information for you.
Yes, it will be helpful if you could get me
Sure.
the total number of
Mhm.
service providers in Ward 7, as well as sharing any gaps that you see, whether it's in substance use or crisis
Oh,
service or
certainly. We have
work
that.
surrounding. Okay.
Mhm.
Could you speak to if there's any plans to expand school-based or after-school behavioral health services in Ward 7?
Well, certainly there is plans to expand school-based behavioral health. Uh,
Okay.
as Dr. Sullivan was mentioning earlier,
Hmm.
we are working right now to make sure that, first of all, every child has access to school-based behavioral health care services. And it may look different in different
Hmm.
places, but we are working with the school leaders in that community and in those communities around the district so that we can determine what kind of model we might want to use to offer those services. I don't know if you want to say anything further.
Copy. Okay. I'm gonna shift to budget and staffing questions, and I know Chairwoman Henderson kind of hit on some budget questions. But could you speak to what percentage of DBH's budget depends on federal funding and how the department is preparing for possible reductions?
First of all, I can tell you where our services are in terms of federal funding.
Mm-hmm.
Um, our SOAR funding, which is a $25 million annual grant that we get from SAMHSA,
Mm-hmm.
is there. We also have our block grant funding that provides funding for service gaps in both mental health and substance use disorder. And we also have some new grants that we've gotten. One to help us prepare for the initiation of a CCBHO, Community Behavioral Healthcare organizational model within the district. And we also have another one on integrated care in the district. And we have certainly funding for our prevention centers and other prevention services in the district, as well as first break psychosis. And so some of our specialty services are funded by the federal government, but I can tell you, I sit every Friday with the other commissioners around the country and
Mm-hmm.
looking at what's happening with SAMHSA on the Hill. It looks like those funds are going to be continued.
Okay, good. And just generally, we've seen in the past that sometimes agencies have to cut their budget by 3%, just to, support other initiatives across the district. As we continue to see these budget reductions, how do you ensure that DBH is making sure that staff who may focus on uh, areas or high need areas rather, that population still gets the services that it needs?
Well, first of all, we are focused on quality of care
Hmm.
and service delivery and making sure that people get the services that they need. And so that's our priority and that's our core function. And so what we're doing is really looking at what is our core function and what things are nice to have, but we might not be able to afford to have. And so
Hmm.
that's kind of the process that we have gone through. And certainly direct service delivery is our core function.
Director, you mentioned that um, key service delivery is your core function. Could you speak to how DBH is tracking uh, the responses, or rather, how are you guys tracking complaints from residents and families who may not get that high service quality?
We have an ombudsman's office
Mm-hmm.
within the department where residents can call directly and they can lodge complaints. And then we have a very thorough process for following up and responding back and doing corrective action if necessary. We also have a hotline that people can
Mm-hmm.
call and can also report any issues that they have.
Now, Director, how are you ensuring that providers are meeting high quality and performance standards?
First of all, we do a number of things to have oversight of our provider community.
Mm-hmm.
We have key performance indicators that we collect data on to see how they're doing on those items. We also have our certification department
Mm-hmm.
that goes out and reviews whether or not they're meeting our certification requirements
Mm-hmm.
or not. We also look at things like we talked about earlier, billing and how many services are being delivered to
Okay.
individuals and outcomes.
Copy. I'm gonna try to get two more questions in, Director. So I want you to be brief as
You don't got
possible.
2 more question time.
Could you speak to what policy changes would be most helpful to DBH's improvement of service delivery?
Hmm.
I know that's a good
I
one.
think here again, the policy change that we are currently implementing is moving from a one-size-fits-all
Mhm.
structure
Okay.
for school-based behavioral health and also moving those services in-house.
Okay.
Those
And then,
policies, those are broad policies that we think will make a difference.
okay, Madam Chair, may I ask one more question?
Is that your last one?
Yes, this is my last one.
Okay, good.
How can the council better support the work of DBH to ensure that you guys are hitting your mission?
Best support the work on.
To support the work of the agency to ensure that you're hitting your mission.
Well, I think that certainly the feedback that we get from the council in terms of our performance is extremely useful, and we take that very seriously, and we use that to make improvements in our service delivery model. We listen very carefully to what people say as they come to testify, and also the feedback that we get from our committee.
Thank you, Director, and thank you, Chairperson.
Thank
Chairwoman,
you.
sorry. Yes, sir.
Thanks. Um, okay, I want to just go back to provider oversight for a moment. So before in my last round, Deputy Director, we were talking about the 2 providers. And my understanding is that they were newly certified providers and the corrective action plan suspensions, et cetera. But it does beg the question, does the department provide additional monitoring when you have new providers who are being onboarded into the system, just to make sure that things are going appropriately? Go ahead.
Thank you. So as a part of new provider onboarding, the provider relations team does a lot of work with them. They have a checklist of things they need to go through, but there's always room for improvement, right? And we have seen, as you mentioned, we may need to revisit some of the monitoring efforts that we're doing. One of those ways that Director Bazran has asked me to revisit that is in restructuring the part of our team that is responsible for provider monitoring and oversight. Previously, we had provider oversight and monitoring in various administrations within our agency. One that people frequently talk about is certification and licensure, which everybody knows me and my team specifically about. But the other group is provider relations. Provider relations sat within a different arm of the administration, But if you think of like a Venn diagram, they were doing similar work to our team. In the time when we have to be really efficient with our resources and tighten up our monitoring, we are going to move both of those teams under my structure so that we can cross-train staff and have more resources, utilize our resources more efficiently to provide enhanced provider monitoring.
Okay, so how many people were in provider relations?
Provider relations had a director, a manager, and I believe 4 provider relations specialists under them, for a total of 6.
Okay, sorry, just writing it down. And how many providers do we have?
We have 77 providers.
Is that enough people?
That is enough people. That is
Okay.
enough people when you combine provider relations with the certification and licensure team.
Okay, how many is on that team?
They have a director, a program assistant, and I believe 7 specialists.
Okay. That was also one of the things, I mean, we had obviously healthcare finance does more than just sort of monitor you guys, but their integrity team is 35 and they're doing an additional contract. Obviously they're keeping track of way more providers and all of those different pieces, but you know, there was some criticism offered earlier this week around the fact that DBH continues to certify providers, and that perhaps we have too many. Do you have any thoughts on that, Dr. Bazaran?
Well, yes, I do, as
Okay.
a matter of fact. We have a very large provider network. It's a little larger than what I'd like to see. We did stop, we have a moratorium currently in terms of new providers, except for substance use and our evidence-based practices. And there's a reason for that. We want to move the system from a community support, which is activities of daily living support, and is not a clinical service, to a clinical model. And so that's one of the reasons why those providers are open. The other thing, though, we want to make sure that we look at network adequacy as one of the things that I've asked my team to look at, to see what should the size of our network be based on the needs of our community. And what do we need to do to right-size that? So I agree with that.
Okay. I mean, you know, it's interesting to sort of hear that kind of feedback as it pertains to certain services. But then on other sides, I know we need more providers, but it's more in the clinical
More on the clinical side.
side of things.
Exactly.
And okay. When should we anticipate this transition of this restructuring to occur in terms of the combination of the teams?
It's begun
Now,
already.
it's already
It's happening now.
Yeah. Uh-huh.
Okay, all right. When you all suspend payment, which if my memory serves me correctly, that's after we've done an investigation and all of this various things, and then there's enough evidence to sort of move on. What does the communication look like with the actual patients to explain to them, hey, your provider is no longer your provider right now? Do we do that loop with folks who might have been attending those particular providers?
Well, first, you want to go? I'll begin, and then I'll turn it over to Ms. Jackson. That first of all, if we suspend payment for a provider, and we make sure that the consumers that are there are getting the care they need, they can transfer if they need to, or they can decide to stay there. You want to talk a little bit more about what happens if they
Thank you,
stay?
Dr. Bazaran. So with the payment suspension, it happens in 2 parts. A payment suspension happens when there's a credible allegation of fraud.
Right.
Yeah.
The investigation is incomplete. And DHCF suspends the Medicaid payment, and they have a statutory process for that. And once we get that notice, we'll suspend the local payment. The provider is not closed when payment suspension happens. The providers avail themselves of their right to appeal and
Mhm.
request an administrative
Right.
review of that. If they succeed, they are permitted to submit claims for the services that happened during the suspension period. So most providers don't stop delivering services. The question about the feedback loop, we have a very prescriptive process when providers close, but not so much with the payment suspension process with notifying clients and consumers with those agencies. So that's good feedback that I can take back to the team. So
Well, because I'd imagine that sometimes it's not just about money. Or at least I hope that sometimes it's about quality of whether or not you're actually receiving the services. And so as a patient, I would like to know, maybe this person, like, this was not the Cadillac of services that I could have been offered. I was getting more of a Honda Coupe. So maybe I want to transfer, but I don't know that if nobody ever tells me
officially.
this is what was alleged, this is what was documented, this is what was found, and here are what your rights are and your options. Because I guess that would be my other question too, right? I spent a lot of time talking about oversight from the perspective of billing and claims, but what does the teams that are doing both provider relations and then also on the certification and licensure side, to what extent are we evaluating the quality to determine, are you meeting the standards? Are you providing good care? Are you, doing
Right.
those pieces as well?
Well, provider relations, first of all, they are, the provider relations team members are really assigned to providers. And so they get to know that operation really well. They then meet with those providers on a routine scheduled basis. They go out and they do unscheduled visits to actually look and review documentation to see what's happening in the facility, to talk to people who are in care. So that's just one piece of it.
Are they possibly too close?
Pardon me?
If you've established a deep relationship with a provider, are you less likely or more likely to report if there's a problem? I'm not suggesting, I have no allegation or claim about that, but I'm wondering if the structure works for
Well,
the.
that's just one part of the structure.
Okay.
Let me go
Okay.
to the other parts of the
Okay.
structure, okay? And then Atia, you could certainly, the other part of the structure is our certification group, where our certification team also goes out. And they certainly, I guess you might say, may have, be a little less connected, and therefore they can also do reviews. So I think there are a variety of different ways that we really have that oversight of the providers, and we're not just expecting one person to do that. And then if there's any credible issues that come up, then we can do it. And in some instances, we may do even joint visits with our partner agencies to look at what's happening. And I'll let you.
So at its basic level, good quality service delivery requires a good clinical assessment,
Right.
which leads to the development of a plan of care, and that plan of care being implemented and monitored by a clinical supervisor. In order for us to do that, the three groups that Dr. Bazaran laid out, we look at claims data on assessments. Are people getting them? We do focus a lot on claims data because that is a truth. We know that a claim was submitted for a service, so we start there, but that's not where we stop. So right now, when we're looking at diagnostic assessments, we had data, I would say maybe in the last fiscal year, that showed the billing wasn't where it should be for the amount of consumers. Every consumer should have at least one. As we look at that in preparation for the hearing and on our routine basis, that has come up some, because in Dr. Bazaran's monthly provider meeting, she raised that we're not seeing as much billing as we should for diagnostic assessments. Then on the plan of care piece, you mentioned earlier our work with DHCF's Quality Improvement Organization, COMAGIN. one of the requirements for getting a prior authorization is that a provider attests that they have that plan of care. So now we're looking at that data in post-pay audits with Comagin to see if the documentation was actually there. And what Comagin has found and shared with us is that in the 10% of audits on post-pay, 90% did not have what they needed. So that tells us we still need to drill down another level with our providers and make sure that they know we're not seeing a connection with what they're attesting they have in the file. The next thing that we look at is the service delivery, and that's through the actual site visits that Dr. Bazran is talking about, where our teams pull random samples of records and review the case notes to determine what work is happening. All of that together presents a picture of care that's being delivered. Where my team can improve is pushing that out to the public and sharing that information. So the next thing Dr. Bazran has asked us to do is push out quarterly reports for individual providers so that they can see where they stand on these various metrics and
Okay.
make course corrections.
So you mentioned the prior authorizations that Comagin handles, but they
Yeah.
do it for community support services.
Right.
Yeah.
Right now, recovery support services does not require prior authorization.
Right.
Do you anticipate changing that?
A resounding yes.
Okay.
Mhm.
Okay. So DBH authorizes ACT directly. ACT requires a minimum of 5 contacts per month and is intended for individuals with obviously severe and persistent mental illness. How do you all determine when a consumer should step down from ACT to a lower level?
Well, first of all, as you know, ACT is provided to individuals with severe and persistent mental illness. Those are the people who are most in need in our system. The ACT team is connected to those individuals and assessing their progress over time, and looking at changes in the treatment plan, changes in their functioning, and whether or not they need to step down to a lower level, because it's the clinical determination.
Okay. Just to close the loop here, were there any providers that closed in FY25?
They're closed what?
That closed in FY25 that you all closed or that voluntarily closed?
Yes.
Yes, we did.
We had a provider who, let me say this differently. Yes, there was a provider who relinquished, and there were many providers where we issued a notice of decertification.
Okay.
Mhm.
Yeah.
I would love to know how many.
11.
11.
11 notices of decertification were issued. But again, as I mentioned earlier, providers avail themselves of their appeal rights. And I would say maybe 5 to 6 of those decertifications are in administrative review.
Correct.
Okay. At the time that they are going through the administrative review process, they're still able to bill?
Yes.
Yes, statutorily, when we issue a notice of decertification and the provider appeals, all action is stayed during the appeals process.
Oh, Lord. Okay, because I'm putting on my other hat of knowing
Oh, and
OAH has a little backlog situation going on.
let me clarify. They can bill, but most of them have their payment suspended, but they're still delivering services. And yes, OAH has a backlog, and OAH often asks us to mediate, as they should.
But she's right. And so what happens is when they say, we are appealing, we have to stop at that moment. And they can continue their service until a decision is rendered.
Do you tell the consumer that a notice of decertification was provided?
I would say not 100% of the time. It's a timing issue. But that's that goes back to your earlier question about our communication to consumers about adverse administrative actions against providers. And we need to increase that communication so consumers are clear.
Okay. Like, the Office of Administrative Hearings, we have great ALJs.
Yes.
They are also severely understaffed for the number of appeals that are coming before them. So it could be months before your decertifications have actually been finalized. And all the while, they are still delivering something to someone potentially, but also billing.
And we continue to provide oversight
Correct.
and monitoring all the while.
Okay. There's something that feels a little off about you all as a regulatory agency, in some cases, perhaps making a clinical judgment that this provider should no longer be providing services. But then the Office of Administrative Hearings that does not have a medical background can make a determination to say, no, they can keep going. Let's just let that
That's a
linger.
Yeah.
Let's let
That's
that
a
linger.
regulation, yeah.
Because that seems crazy.
I would offer a different opinion.
Okay, maybe, from an administrative standpoint, perhaps you all didn't do, something paperwork wise didn't happen, right? But I'm like, is OAH the appropriate right jurisdiction to sort of manage those types of questions?
OAH has to have a broad scope of responsibility with the ALJs, not just for our agency, but many agencies.
Yeah.
The ALJ or the attorneys representing the cases aren't always clinicians or subject matter experts in whatever regulatory scope that is. That does not mean they can't review the rules and hear the case. Because even though, as you mentioned, we're making a clinical judgment, the clinical judgment is grounded in our regulatory requirements. We can't just say, this doesn't sound right, because clinical work is an art form too. The regulations say you have to do A, B, C, and D, as evidenced by X, Y, and Z. When we did our reviews, that was not there. So I hear what you're saying, but it's also, a regulatory practice that we support the ALJ and the lawyers' ability to review those.
I was just handed a spreadsheet. There's always a spreadsheet and a data for things, but like, we've got providers where you all initiated the decertification in January of 2024. But, okay. All right.
Yes.
Okay. Something for OAH hearing on another day. All right, let's talk about CPEP and 35K.
About,
CPEP.
okay.
So on Monday, a public witness raised concerns about how individuals who require medical clearance are handled when they are involuntarily hospitalized, particularly individuals who chronically homeless or living with chronically homeless and living with serious and persistent mental illness. As it was described to the committee, this is what we heard. When medical clearance is needed, individuals are often transported to from CPEP to a local hospital because CPEP is not currently equipped to manage that process on site. Witnesses indicated that this can often result in significant delays or hospital discharges that do not include a return to CPEP, therefore limiting the access to mental health stabilization. So what's the current process for obtaining medical clearance for individuals who are involuntarily hospitalized through CPEP?
Yes, first of all, we are a psychiatric facility that focuses there. And we do some screening in terms of primary health care, but we are not a healthcare facility that can handle all issues. I'll have our Chief Clinical Officer, Dr. Shepard, respond, who has oversight for that facility.
So good morning, Chairperson Henderson, and good morning, everyone. Chief Clinical Officer Jonathan Shepard for DBH. So in response to that question, When a person comes into CPEP, they're normally under some type of mental health disorder, some type of mental health crisis. During that particular assessment or evaluation, that person may be in the middle of a medical issue like hypertension, diabetes, something like that. Unfortunately, at the time right now, we don't have any primary care physicians at CPEP. And so what we do, we will send those persons to one of our contracted hospitals for the medical clearance. And then many times those persons are returned back to CPEP. I'm only aware of one incident where that happened, where the person was going to be admitted to the hospital and they ended up staying at the hospital once they got the medical clearance. But I am not aware of where this is a big problem. People return back to CPEP after the medical clearance.
Okay, is it not more efficient for CPAP to have perhaps like a nurse practitioner on staff who can handle a higher level of?
Yeah.
I mean, I imagine that number one, it takes time for transport. It requires staffing away, right? Somebody has to move that person from one location to an area hospital, and you can't just drop them off at the waiting room door. Somebody has to sit and do all those things. Would it not be more efficient for minor related health issues that there be someone at CPEP who can provide care?
So the nursing staff and the physicians there, I mean, so they're physicians. So psychiatrists can take care of simple medical
Minor,
issues. But when we send people out, this is a critical issue. So typically there's something that is saying that there needs to be more monitoring to make sure that those particular issues can be addressed. We don't want someone dying at CPEP because someone was trying to take care of them and we didn't have the proper monitoring. I'll also say this too, to hire a nurse practitioner versus transporting out, we need to look at what the financial piece is for that too.
Everything costs money. It costs money to transport.
Well, that's true, but it might be more to hire a nurse practitioner. They're
Okay.
not cheap.
You're
But
right.
also, we
They're
want to
not
make
cheap.
sure that people get the care that they need.
Yes, we obviously want to make sure that folks get the care
Right.
that they need too. But again, when we're thinking about it, even from the perspective of like hospital emergency rooms, for instance, right? There are a lot of hospitals now that are moving towards having urgent care within the hospital. So I could say, hey, you don't have to sit here for 15 hours, walk down the hall and they can see you in 15 minutes for the nosebleed that you have or whatever it is. So I'm just sort of thinking about from the efficiency standpoint there. Okay, Dr. Bowser, I'm gonna give you an opportunity to clear up the rumor mill. Is CPEP moving?
Yes.
Where are you going?
35K Street, that is our proposed location.
Okay, why?
Have you seen the facility and where it's located? And also, one of the things to note is that there's major construction in that area.
Yeah.
And there are only literally two buildings still standing. And we have been notified that all of that's going to be mowed down. There's going to be a road there. And so there will be no building there. So,
Oh, I'm sorry. You said they're building a road there? Is that what you said?
yes,
Oh,
CPAP will be a road.
CPEP will be a road. And so we had to really work with our DGS partner to identify where we could move this valuable service. And that's why 35K was selected. We are going to do some renovation of 35K Street.
okay.
So that we can accommodate CPEP there. It's a great location in terms of where it is.
Is there
It
enough
not-
space? Because I feel like 35K
Yes, there is
is
enough space.
like
We have,
doing a
as
lot.
a matter of fact, we had a walkthrough with the director of DGS and some of their staff, and there will be an architectural assessment to make sure
Okay.
that we can actually have all the services there. That's a really big building, and we're talking about putting them on the second and third floor of that building, and you have the stabilization center on the first floor of the building. It's the other side of the building.
Right. No, I was just sort of thinking from a perspective of like, we got a lot going on at that particular location with the pharmacy plus the stabilization center. So now adding CPEP, that seems like a lot of moving pieces.
Well, actually, I think that it's useful to have them all there because first of all, we know we have individuals with co-occurring disorders.
Yeah.
Who may need to have the ability to have both services. We do have psychiatrists on site there. And so quite frankly, from a clinical perspective and an integrated care perspective, it does make some sense.
Okay.
And we can't allow it to be where it is, where it's going to be a road, because we can't afford not to have it.
Okay.
So,
We've been joined by Councilmember Brianna Nadeau, who's a member of this committee. Councilmember Nadeau, I'm just going to ask one more 35 K Street question, and then it's on to you. Is the 35 K Street pharmacy closing?
yes, we plan to close the 35K pharmacy. And here again, our chief clinical officer can give more details, but we're finding that the utilization is so low, like, 10 scripts a week. And it really, from an efficiency standpoint, is difficult to continue to manage that. And also, people can go to the pharmacy and get their prescription drugs.
What if I need an emergency script, though?
If you need an emergency script,
Or an emergency, what do we call it? Like emergency access to medication? No. Go ahead. Sorry.
So I want to make sure I'm understanding the question that you're asking. So if someone needs medication on the spot, is that what you're?
Yes, so I was sort of thinking from a perspective, one of the reasons, if we draw out further, right? When we have these conversations about the court urgent care clinic, one of the things that you all have often offered is, oh no, everybody could just go to 35 K Street to sort of get all of their needs kind of handled and met. And I know that one of the things that they're able to offer at the court urgent care clinic is to be able to say, if you needed evaluation, if you needed an emergency, like prescription, et cetera, they can sort of handle that assessment and diagnostic right there at the courthouse. But you all have said, nope, you could just go to 35K. So now if I'm going to 35K, are the same amount of services there that I can meet my needs, is all I'm saying.
Yeah, I think I understand what you're asking. And so in regards to the pharmacy, you have to have a prescription in order to be able to get. So that person can still take that prescription to a neighborhood pharmacy. I mean, you just don't come to 35K and say, hey, I need such medication.
Right.
There still has to be a prescription.
Right.
So that person can take a prescription to another pharmacy in the neighborhood and it'll be just as fast.
Okay. All right. Councilmember Nadeau?
Thank you very much, Madam Chair. Dr. Bazran, thank you for touching on the loss of behavioral health coverage due to Alliance and Medicaid changes in your opening statement. I appreciate that DBH is monitoring the impacts. The district has made a lot of progress in access to treatment for SUD and other behavioral health conditions, and it's very concerning to me that so many of our residents have lost this access to care. I want to clarify a few points that you made. First, you said that DBH coverage eligibility has changed to match that of Alliance and Medicaid, meaning that DBH is no longer covering care for individuals who make under 200% of the federal poverty level. Is that correct?
That's correct.
Okay.
Yeah, we are using the same guidelines as DHCF.
Okay.
We will be consistent with that.
And how has this been communicated to the providers and residents? We heard some testimony on Monday that there'd been some confusion about the coverage.
First of all, there has been significant communication between both DHCF as well as from the Department of Behavioral Health. We actually have Bulletin 157, which really outlines our posture and our policy, and it has been widely distributed. And we have also talked about that very widely within our provider meetings. Mr. Neff, I don't know if you want to add anything?
I would just say that, we receive claims on a weekly basis from providers. So we are tracking both former Medicaid covered beneficiaries along with Alliance members who have lost coverage. So we have a way of identifying them when they're accessing care. And in a situation where last week we had a consumer who was in an ACT service. So we were able to work with the provider to put in an authorization segment to pay for it with local dollars, so that wasn't interrupted.
And the other thing, too, council member, that I want to make sure everybody is aware of, and that is if somebody is in ACT and needs the highest level of services, which is ACT, regardless of whether or not they're meeting the income eligibility requirements that have been established, we will pay out of local dollars for that and make sure that they continue to get the services they need.
Okay, that's helpful to know. And that includes both Medicaid and Alliance.
Mhm. Yes.
Okay. I wanted to ask, so I'm glad to hear you're tracking it. I also wanted to ask about some of the numbers you shared in your testimony. You said that around 220 people had lost coverage due to Alliance changes, and around 30 have lost coverage due to Medicaid changes. Can you clarify, how do we have those? How are we ascertaining those numbers? Because and I'll say this, DC Healthcare Finance has said that thousands have lost coverage due to the changes. And we heard from one clinic on Monday that nearly half of their SUD patients lost coverage in October.
Mm-hmm.
Sure.
Given data.
Yeah, so we receive a weekly eligibility file, and we're able to look at program codes and compare who was covered previously to who is presenting. And that's how we track it and get our numbers. There's also codes that have identified people who previously had Medicaid. The reason that Medicaid number is less because that change happened January 1. And we don't know until someone's accessing our system. You know, it's not like we get a per member per month, like
Right.
an MCO would. So we get everybody's eligibility. You have to access our system. So
Got it. So DC Healthcare Finance, they would know those numbers better than you, basically because they're processing the coverage.
yeah, I mean, they would look back over a period of time, and they have, and they've shared with us everybody who received ACT service. So we would know overall how many people that might be within a larger group. But the numbers are much smaller for people who have lost coverage versus those who have lost coverage that are actually accessing behavioral health services.
So it sounds like, don't let me put words in your mouth, but based on what you've said so far, it sounds like you would say people aren't losing treatment options because we are covering them with local dollars.
No.
No,
No?
we are not we're covering what we consider high risk services. So assertive community treatment, inpatient services, of course, would be covered. CRT, CPAP, those crisis and higher levels of care, we will enroll based on their presentation and work with the provider. But for things like community support, losing eligibility means we don't offer the service anymore.
Got it. So what we should be worried about, or what I'm worried about then, is the downstream effects for sort of the preventive side, because it sounds like you're covering the acute side, but now we're back in a place where we were, say, pre-ACA, where everyone's just getting care when it's an emergency, and we're not being able to, we don't have the lower level services covered anymore. Is that accurate?
I would say ACT is, well, often referred to as hospital without walls, right? So it's not acute, it's a subacute service in that sense.
Okay.
But it is our highest level of community-based care, and we would cover
Okay.
that.
Okay. So what are the services that we have covered in the past that are now not covered that we should be thinking about, or that we should be worrying about?
Yes, the basic MHRS services that people have received through our local-only benefit. If they do not meet the eligibility guidelines, they would not receive those services.
Okay.
Other than ACT.
Uh-huh.
Mhm.
I did take a look at the CRT and CHAMPS data that you shared in the pre-hearing responses. I am concerned that there have already been 4 MPD involvements for people under 17 and under so far in FY26 compared to only 6 in all of FY25. I also see that the average call response time is up, and these types of trends are concerning to see, knowing that so many residents have lost access to care. Are you concerned about that as well?
Yes, we're concerned. I just want to clarify I double checked the CHAMPS data response time today. And the spreadsheet that we had was actually adding all 3 of the response times. So it's actually about 36 minutes for fiscal year 26 for the CHAMPS response. So it's similar to what it was in the previous year. Just wanted to clarify that. We are clearly monitoring. I think you're aware that CHAMPS provides services during the day, and then our CRT picks up those calls at 8 p.m. So we are monitoring that data. What we are seeing is that there's a decrease in deployment. So in 25 of the calls for CHAMPS, about a third or 33% were deployed. And in 26, it's been about 17%. So there's a decrease in the number of deployments as well as the number of calls. So we're closely monitoring it, and obviously our teams between CRT and CHAMPS are collaborating so that we ensure that our data can be shared.
Thank you. Dr. Bazran, I have a few questions about the Stabilization Center. DBH has been a really great partner on this over the past year. I mean, the one in Columbia Heights, of course, and the community meetings have been so helpful for offering folks a chance to engage in the process. I know we had a few questions about the last meeting. I'm wondering if DBH plans to post the recording and a meeting summary again.
Yes, well, one of the things that we're excited about is the second stabilization center, and you had an opportunity to see the drawings. It's going to be a great facility. One of the things that we have noticed is that the opening may be later than what we had anticipated, and we are waiting for confirmation of that, but we are moving forward with that process.
Great. And then just let us know if you could when the recording and the meeting summary is
Absolutely.
posted. We'll help get that out to the community. My office has gotten this question a few times, but both the K Street and the Park Road Center use local funds to operate.
What is she? I'm sorry if she said.
Do both stabilization centers use local dollars to operate?
Well, first of all, there's a blended funded process. So we give startup dollars when they are just opening up, and those startup dollars can be, depending upon a need, a combination of SOAR dollars and some local funds. And then we do expect that they will be certified as Medicaid providers. And then over time, that local portion will decrease as it has with the current stabilization center, and the billing will pay for the service.
Thank you. Thank you, Madam Chair. I'll come back with a few more questions in the next round.
Okay, we've been joined by Councilmember Zachary Parker from Ward 5, who's a member of this committee. Councilmember Parker.
Thank you, Chairperson Henderson, and it's good to see you again, Dr. Bazran.
Hello.
I'm gonna jump around a little bit, but in your responses, you state that evaluations were completed for 98% of eligible employees, and the performance improvement plans are being developed for those receiving a performance rating of 2 or less.
That's right.
How many employees currently need performance improvement plans internally?
I'm not sure of the numbers, but I can get that for you. But one of the directions that I've given is to look at how many fall in that area, and their managers have been instructed to develop performance plans for them.
It would be helpful to know
And so
how
I can
many,
certainly get you that
it would be
number.
helpful to know
Okay.
how many and which teams or
Okay,
divisions
certainly,
they
we can
are
do
within
that.
the agency. Um, Because I think that is important as it relates to the
Sure.
performance of the agency.
Right.
When DBH receives a substantiated investigative report and recommendations are made, what is the process for follow-up from the agency?
If it's substantiated, we do whatever has been, and we've been directed to do with respect to the findings.
Okay, it seems like there were a number of serious incidents last fiscal year, illegal weapons and workplace violence, where training was recommended by DBH. How do you ensure that the training is actually completed?
Well, first of all, we track whether or not the person has gone to the appropriate training. We identify the training, we tell them what it is, and then we track whether or not they have attended or not attended.
And can you provide those numbers? Like, it would be helpful for every investigative
Mhm.
recommendation, there's a follow-up to say this person actually completed what we recommended or not.
Mhm.
Yep.
Hi, Atia
I don't know if you
Jackson.
need to be sworn in or not.
Mm-mm.
Okay, okay.
Go ahead.
Atia Jackson, I'm the Senior Deputy Director, and the response you're reviewing about investigations is from my team. Yes, we follow up on the recommendations, but what I hear you requesting is in the responses. You need to have
Mhm.
that. We'll provide it.
And we'll provide that.
Mhm.
Mhm.
Yes, yes, okay. When there are investigations for improper billing and providers are placed on suspended payment, are there any payments that that they continue to receive from DBH during that period?
No,
So all payments are
we
suspended?
suspend the payment for their service delivery,
And
yes.
how long do these types of investigations take?
A very long time.
That's what I was gonna say, a long time.
Yeah.
Yeah, it depends, it's a long.
Can you give me a ballpark? Are we talking weeks, months?
It can be years.
It could be
So
years.
let me start a little bit
Mhm.
upstream.
Yeah.
When a payment is suspended by DHCF, it can be suspended per federal regulations for a credible allegation of fraud. So the full investigation has not been completed at that point, but there's a credible allegation of fraud. Once DHCF suspends the Medicaid payment, we're informed and DBH suspends the local payment.
Mhm.
And what happens to the clients of that provider during this period?
Yeah, we had a round
They
of questions
continue-
about that. Thank you.
Yeah.
So there's
Oh,
some
I
synergy
missed
They
there.
that.
continue to get service.
Yeah, so when payments are suspended, it does not equate to a decertification. The
Mhm.
provider is still open and can continue business. Many providers choose to.
With no payment?
Doesn't that
Correct.
sound
Well, how-
interesting?
Uh-huh.
Many providers choose to do that
Mhm.
because once they get the payment suspension letter, they can appeal. The first appeal goes to DHCF as an administrative review. If they are successful on appeal, all of the services that they've been delivering and the claims that they've
They could
been
recoup
Get paid
payment.
on hold, they can
Mhm.
submit them and get paid for that.
And how often does that happen?
That happens 9 times out of 10. Many providers continue to.
In other words,
deliver
that what
services.
might have been suspected as fraud turns out actually not to be fraud, and they can continue moving.
No, that's a
forward.
different question.
Yeah, that's a different question. You're
Well, if
asking-
you're telling me, if they are recouping the funding, I'm assuming that means because suspension has been lifted.
I'm not understanding your question. Please restate.
You're saying that many providers continue to provide services because later down the line, after there is an appeal, they can recoup the money from
Correct.
those services.
If the appeal results in supporting their position,
That
that there was no
fraud.
wrongdoing,
Yes,
then yes, they get
and
all
you're
of the
saying
money
9
that
times
they.
out of 10,
that
that
they
is
were
what
billed.
happens.
No, not 9 times. Let's separate that out, the 9
Oh,
times out of
okay.
10, because you want to know how often does the provider prevail? Isn't it?
Yes.
That's the 9, which is a different question.
So how often does the provider prevail?
Okay, that's the question.
I do not have the numbers in front of me, and I don't want to hazard a guess because this committee will. hold you
Understood,
to-
but what was the 9 times out of 10 in
I was
reference
speaking
to?
to 9 times out of 10. I was speaking to 9 times out of 10. When a payment suspension letter lands at a provider's lap, they're going to file an administrative appeal.
I got
Right.
it. I got it. I got
Mhm.
it. I got it. Okay, let me move on. 59% of school-based behavioral health partnership schools have a school-based behavioral health provider, which fell below the 70% target. And I know you're revamping the program. Where are we today with that revamp?
Dr. Sullivan?
Sure. So you're looking at the KPI from last year. Today, we're at about 77%. As you know, we have been working on a comprehensive plan and have shifted the model from one size fits all to a more diversified model. And so now we currently have about 116 schools that are staffed with a CBO, 59 schools are staffed with clinicians from DBH hired. We have a few schools that are receiving their own funds and have hired their own staff. And then we
And that
also,
was a big sticking point, I know, for some schools,
Right.
that they
Yeah.
wanted to build
Correct.
capacity in-house.
Mhm.
And so I'm glad to hear that you're doing that. Because I was told that you had administered or had an RFP out and
We
no
had
one
no-
applied.
Yes, that's
And so
right.
you had stopped doing it, but now it sounds like you're doing it again.
so a few years ago, we put out an RFA.
Right.
There was specific criteria. Some schools applied. This past school year, so 2 years ago, they struggled to hire, which we shared. What we chose to do this year moving forward was we did put out an RFA, but the decision was to only allow those 8 schools that previously
That
had
originally
it,
Correct.
applied.
because there was so much, again, it was
Understood.
very hard for them.
And how many schools applied the second time around?
3.
3.
Mm-hmm.
Can you name the schools?
2 are LC Stokes, and I'm blanking on the other, but I.
DC Prep, is that one of them?
No,
Mm-mm.
DC Prep they did not meet the original criteria, because one of the criteria was you had to have a vacancy for a year. They did not meet that first one, and so they were not able to apply. And so they were not part of that cohort of 8.
Got it. Or cohort of 3.
Right, or the now cohort of 3, where they do, we have worked with them pretty extensively. They do have 2 CBO funded clinicians in their schools.
Mhm.
They also recently, I think the beginning of the school year, also we hired within DBH and have placed a clinician at 2 of their schools. And so I think they have 2 openings right now, which we are working to hire to help support those buildings.
Got it. I would love to follow up offline because
Sure.
I've just heard from them that they would love to have support for their in-house program. And it seems like you're well aware of that.
Yep.
What is the process or goal to scale success? It seems like you've made progress. Now we're at 77% of schools with
Right.
coverage. What's the goal to move forward?
So the goal really is, as I mentioned before, it's about looking at ensuring that there's access for all students, right? And so part of the comprehensive plan is shifting from that one size fits all to really looking at what the needs of the school are and looking and providing resources based on that allocation, right? And so how we're shifting now, and part of our comprehensive plan, is to shift and move towards, currently we're in a hybrid model. In the next year, we will be continuing a hybrid model, but we will be reducing the number of CBO clinicians and increasing the number of DBH hired FTEs in-house so that we have more flexibility. Kind of mirroring what we've done in the last several months.
More flexibility, read higher caseloads?
No, not necessarily. Really trying to match, instead of forcing one licensed clinician into every building, really looking at the data, having conversations with the leadership at the school, as well as our educational partners, and looking at what are your needs? Does it make sense for you? Do you already have 5 licensed clinicians in the building and don't really need support in treatment, but you're really struggling in prevention, right?
Understood.
And so we would then allocate the appropriate resource. And what I mean about flexibility is we're broadening our ability to provide services. So not only looking at social workers, which we've only hired licensed, independently licensed social workers in the past, we now hire LGs. We've also, over the last few months, expanded to include other disciplines, including licensed professional counselors, LMFTs. We're also soon to be posting what we call a prevention specialist, which is an individual who is not licensed but has knowledge and expertise in providing services in schools. But it would be somebody who could go into the classroom and implement something like Too Good for Violence or Too Good for Drugs. And we wouldn't necessarily be having to use that highly licensed individual to provide
Understood.
it.
Well, I'm over time.
Oh.
Thank you for your response. Thank you.
Thank you, Councilmember Parker. I'll just pick up there on school-based. So, you all have described this as a multi-year transition, yet many of the core elements, staffing, data systems, crisis response roles, the evaluation framework, are still being developed in real time. Are you still confident or comfortable with the timeline that we talked about last year in terms of implementation of this new model? And it's okay to say, no, we're not going to move on that same timeline.
Well, I think that one of the things that we do want to do is work with the school leaders, look at what our data is looking like, look at what our hiring rate is looking like, and make that determination based on the data.
Okay, so where are we in hiring right now? So I believe that for FY '26, the goal, or not the goal, but I think you had 25 FTEs that were available. Where are we at?
Correct. So as I mentioned, we just changed all the PDs. We've hired 2 clinicians, 1 supervisor. We currently have 4 clinician positions posted. I think today's Wednesday. Our goal is to have an additional 4 clinical positions posted by the end of the week, which would give us 11 clinical positions posted or hired, and we're hoping to have those positions hired by March. That is a little bit less than half.
Okay.
And we're also,
That's aggressive.
It's aggressive.
but our hope is to really try to cover some of the schools. As you know, I think there's 52 right now that are not receiving resources.
Yeah.
And so again, while those 11 people are not going to be able to plug all of those holes and needs, we're hoping to get some of the clinicians into those buildings. The other piece of that 24 or 25 FTEs is around the prevention specialists that we're talking about. So this is a new position for us. And so it's taking a little bit longer. We obviously had to create the PD. That's completed. And we're currently working with the HR to, on the path of posting those in the coming months.
Okay.
And also because they're unlicensed, there's a broader pool in terms of the workforce for that particular position.
For prevention specialists,
Prevention,
yes.
yes.
But for the clinician, I
Right.
mean, did you tell Councilmember Parker you guys are hiring LGWs now? What, licensed graduate social? Okay. That will help. That'll be different.
Yeah.
I know that we've said this a few times. We've had a lot of interest in our positions, both, previously in the last 6 months, but we're also hearing, people are like, when's it going to be posted? And so, again, workforce is an issue and we're very aware of that.
I just don't want us to ever be in sort of a desperate posture of we start hiring people just to fill a body as opposed to hiring the qualified person.
No.
I'd rather there be a vacancy than you hire somebody who is
Absolutely.
not equipped to
No.
do the job.
Yes, and I think we definitely agree with that. I think if you knew our supervisors and hiring teams, I think they hold a very high standard.
Great. Continue to do so.
Yeah.
So we're talking about young people here, and I don't ever feel like young people should be, yes, in a supervised clinical space, sure. This could be an opportunity or a training ground for someone to become great. They also
Right.
should not be guinea pigs and sort of, if we don't feel like somebody is there, let the position stay vacant until we find.
Exactly. And I think that we've experienced that where we've had 12 people on a certification
Yeah.
saying that they qualify, and only a few of those were actually hired. We're not just hiring them based on the fact that they have the proper credential, but can they do the work? And can they deliver the service? The quality is what's most important.
Okay, so
And
it
particularly
sounded,
for our kids.
it sounded like though on this particular timeline that for school year 26, 27, you're going to have some CBOs who are still providing care.
Mhm.
Okay. I don't know to what extent you all can say that in the affirmative, but I think it would perhaps give some calming waters in the CBO provider community, who many think that at the end of school year, this school year, 25, 26, you all are just going to send out a bunch of termination notices. And so to the extent that you can sort of have that conversation around, this is what our real transition plan looks like, or not real, but this is our realistic expectation based on the information that we have today. We do anticipate that CBOs will be continuing into the next school year, and we look forward to working with you. I don't know what
No.
that looks like, but I do feel like there's a lot of nervousness now that you all are just going to cut it off at the end of this school year.
Well, we've never planned on just, and I think we have been very clear as we've talked to folks that we know that we will need some providers who provide specialty services, like bilingual services and some other services. And so we will need to have that support as we move forward. But I take your point, and I think that's where we're moving.
Okay, great. I don't want to steal Councilmember Parker's thunder because I'm sure he's going to ask you a bunch of questions about youth. Okay, so I'm gonna talk about housing then. Okay, so first let me start with thank you to your team for following up with the public witness who testified on Monday. I think you all did contact her about the particular issue that they were having with the building up in Northwest on 14. Okay. Let's talk about the SAMHSA funded projects for assistance in transition from homelessness. This is the PATH program. It showed the data that you all provided to us showed a decline in housing outcomes from FY24 to FY26 to date. So only 10 individuals have actually achieved housing out of the 271 individuals that you engaged, or the 66 that you all connected to a core service agency. What factors are contributing to this decline in both placement rates and absolute numbers?
Well, first of all, I'd like to step back and say that we are working very closely with DHS in terms of our outreach to individuals who are unhoused. They have a by name list of individuals that they want to pay close attention to. And we have really used our teams, our PATH team, as well as our ICC team, along with, in partnership with their teams, to address the needs of those individuals. I think that a part of it is that it takes a lot in terms of engagement. Sometimes it takes months and years to engage individuals and get them to the point where they're willing to go inside. We do use the critical time intervention model which is an evidence-based practice, which is designed to help us begin to get people on that road to thinking about coming inside, but it's difficult. And we're continuing to work on it. I think you know that we have really worked together with DHS as well as with our public health service partners to do that.
Asking this in part too, because I know there was like a recent announcement this week from the feds, right? They seem to be leaning in on this housing component when it comes to the SAMHSA work. Which I think then requires states and local jurisdictions to also lean in on this housing component in terms of this work as well. And we just always hope to see a higher number than just 10 people connected.
Yeah, well, actually, Councilwoman, I'd like to say that the results from this joint effort have been very positive.
Okay.
In terms of not only the engagement, but also getting some people into housing. We have really crafted a model that is includes not only just the outreach and engagement on the street, but then coming back and then doing a clinical review of an individual and thinking together about what is the best way to address this person. Who knows them? Working with the people who've been working with them on the street all the time for sometimes months and months. How do we, begin to make that connection and that trust and build that trust? And so I think that that's the last report that I've received, and Dr. Moise can certainly share additional information. It looks like that's been a good thing, and
Okay.
it's been really moving. And I can tell you that the federal partners were extremely pleased and said that they felt that the model was actually a model that should be spread across the country.
Okay. I'll have some more questions on housing, but I'm trying to model good behavior for my colleagues. But also, I want to just let you know, Dr. Bazaran, so after Councilmember Renado goes on her round and Councilmember Parker goes on his round, I'll give you a break. So just think, it's 20 more minutes, but it's coming. All right, Councilmember Renado.
Okay, thank you.
Thanks. I may not take my full 10. I just have a couple more questions. Okay, Director, I also wanted to ask about DBH grants. Have all of the grants for the FY26 substance use and behavioral health services targeted outreach grants been issued?
Yes.
Great. Okay.
Yes.
Yes. Okay, great. All right. So, and we did get a chance to talk about this program recently at the December hearing for my bill to make the Community Navigator Grant program permanent. I know the DBH is getting regular reports from grantees about program activities, including number of residents being served. Does DBH plan to publish any of these, or is this something that we can see at the committee?
We haven't really made any specific plans to publish a report, but I think that that's something that we can investigate.
Okay,
An
great.
outreach report.
That's all I have for you today. I really appreciate your testimony. Thank you, Madam Chair.
Okay, thank you, Councilmember Renado. Councilmember Parker.
Awesome. Thank you. I was kind of not ready because I thought I had more time. Let's talk about St. Elizabeth's. And it's the gift that just keeps on giving. I will say, and I will say this respectfully, I think the hearing that this committee had, 2 weeks ago, may have been the most troubling hearing I've sat through during my time on the council. And the reason for that is that we're dealing with a very vulnerable population, and it just seemed as though the testimony we were hearing spoke to misdiagnosis, medication being prescribed in the wrong way, overdoses perhaps being undercalculated or not calculated. There were allegations of people using identification and badges that perhaps were not their own. There were financial charges and a host of other things, so much so that I think Chairperson Henderson said she was going to make referrals to the Inspector General just to see what's going on there. I would just generally ask, what is your assessment of St. Elizabeth's, and what is your focus in right sizing what's happening there?
Thank you for that question. First of all, I work very closely with Mr. Chastang, the CEO, and do supervision with him on a routine basis. And there are a couple of things that we're doing. One is we really have prioritized all of the operational issues that are identified for St. Elizabeth's Hospital, and we have a tick list. And we're going through each one to make sure that those things get corrected. On the clinical side, also, I have asked our doctors.
And have you, I'm sorry to interrupt, but have you shared that hit list with the committee?
No, we have not. No,
you-
it's the list
Can
of
you name just the top 3 things on that list?
top 3 things. One was developing a tracking system that we talked ad nauseum about, a long time about, in terms of inventory management. The second thing is looking at the staffing configuration. Is it the appropriate staffing configuration for the population that we're currently serving or not? Looking at things like making sure that we have adequate supplies and a way to get those supplies immediately to the individuals that are on the wards. So, I mean, there's, and so forth.
And can you share that hit list with the committee?
Sure.
And I know we also had a hearing with Deputy Mayor Turnage, and it sounds like there's going to be biweekly or monthly meetings with you,
Yes.
him, and others within the hospital.
Right. Deputy Mayor Turnage and I will be meeting every 3 weeks. And as a matter of fact, we just got confirmation from the unions that they have agreed to those meetings. And what we will do is identify what they see as issues and then follow up in terms of whether or not they're resolved and keep, a continuous list of that.
I love to hear that. I'm grateful to hear that. As a member of the committee, I would just love line in sight. Now, I asked Deputy Mayor Turnage, would he be open to members of the council joining those meetings? And he, in his own way, said no. I'm paraphrasing. He didn't say no, but he said, in his own way, no. How do we get information from those meetings or readouts or updates to just know that you are in fact making progress?
We can provide updates. I will talk to Deputy Mayor about what
And
the process
obviously-
might look like.
Share that with the chair of this committee. The committee, as a member, I would be eager to just know, because again, I left deeply troubled, so much so I had
Right.
dinner that evening, and I think half my dinner was about the testimony that we heard, which was just deeply troubling. I do have some more questions. What does St. Elizabeth's identify as the main cause for readmissions within 30 days?
Okay.
We frequently don't have readmissions within 30 days.
What is the number?
Probably 0 in the last 12 months.
Mhm.
There may be rare instances where there's something extraordinary happens, but rarely does it happen.
And
I'm
I
happy to
noticed,
send you,
sorry.
I'm happy to send you the data for the last 12 months if you'd like. The committee.
And I noticed that that KPI was removed. Is that why? Because you would argue,
Probably.
okay.
If it's been 0 for an extended period, KPIs are established for the reason we all know, and that is to improve, to focus on a particular issue that improves overall quality or safety or whatever the metric is attempting to improve, performance improvement.
And I remember at the hearing, there was information that you all were supposed to get about the number of overdoses, because there was discrepancy. We heard testimony that there were frequent overdoses. There was one, I forget the young woman's title, but she was saying she advised her manager. The manager essentially said, tell me, but don't officially report it. And I asked, what are the numbers of overdoses happening at St. Elizabeth? And I was told you all didn't have the number, but you would follow up. Do we have that number?
Yeah, we did not have any reported overdoses for the last 24 months. I met with the staff.
So the number is
As recent
0.
as yesterday. What period of time would you?
So you're saying the number is 0 in the last 24 months, in the last 2 years,
Yes,
that there are no prescription overdoses?
that's correct. That's what was reported to me. Now, keep in mind how, first of all, I was at the hearing and I'm at the hospital every day. And there were no specifics in the testimony of the individual who made comments about St. Elizabeth Hospital. And that individual had not been to the hospital in over 6-7 years. And has no direct involvement in any aspect of the hospital's operation. With that as backdrop, if there's some specifics, we will investigate it very thoroughly, seriously, and respond to it from a performance improvement perspective. We administer over 800,000 doses of medications annually. Is it possible that we had some event that fell outside of best practices? Yes. And so that's the perspective I offer you.
And how are you all documenting those mistakes?
We immediately do an incident report. We constantly monitor medication management in every aspect.
Okay.
We have a committee of professionals.
I only got 2 more
pharmacists.
minutes, and I have a whole nother section of questions. I'm
Yeah,
sorry.
Very important.
The other, that was helpful. So what I'm hearing you say is in the last 2 years, your position is there are no overdoses at the hospital, which I believe is contrary to the testimony that the committee received. But one other point of,
But there was no specifics in the committee, in the comments. If we're referring to the comments the ex-employee made about the hospital, there were no specifics, so we couldn't follow up
okay.
on a specific incident.
The other was about medical restraints. And then I forget the gentleman's name, but there was a whole back and forth. And to me, it felt like legal jargon, whether it's medical restraint or chemical restraint. The point is that people are being prescribed something
Yes.
that is rendering them sedated. And then there was a question how often that was happening, and there wasn't a clear answer. Do we have data on how often these medical or chemical restraint, let's not say chemical, how often these medical restraints are happening?
Yes.
And where can we find that data?
What period of time would you like? the
Let's
date?
say the last year or last 2 years.
I'll provide that for you. I don't have it.
That would be,
Thank
that
you.
to me was also really alarming, because what that says, and I get it, safety is a reason and people need to be restrained in certain instances. I do respect and get that. But the testimony suggested that it was happening more regularly than necessary. And the gentleman, I can't remember his name, he essentially said, well, this is what is prescribed as part of their medical plan. I'm paraphrasing. And it just calls the question, why is sedation the solution versus some other option?
Because if it happens, when it happens, it's in the patient's best interest. And it's done very carefully, ethically, within the guardrails of legal constraints.
Okay. Chairperson Henderson, could I have 2 more minutes before we go to break? And I promise you, I just want to pivot to another topic. And okay, I did want to come to, let me just ask this. Your relationship, the data limitations with family court social services, our friends, and you're working with juveniles in the court system. Part of your responses alluded to not having full access to data, and we know that that is an issue across government. But given your stated lack of access to the full family court social services division universe, what steps are being taken to improve interagency data sharing to track the number of youth receiving CBI services through court social services and to assess service overlap or gaps? And of course, that's more than we're at time.
It's okay.
I'm
Because, sorry, I know Dr. Bazran, I said after Councilmember Parker is done, but I have some follow-up questions on St. Elizabeth that I want him to be here for, because I feel like
okay, well, why don't we stop here? Let's not answer that question. And I would love, yes.
Okay.
Sorry
'cause
about that.
Semantics are important, and I learned this from, I think it was the chief medical director, right? Chemical restraint versus sedation. Everybody got a different definition, but actively does the same thing. So question. All right. So Mr. Chastain, you said there were no overdoses in the last 24 months.
No, that's what was reported to me.
Okay.
But you have to define what you mean.
No, that's
by
what I know you were going to say that.
Yes, of
I know.
course.
So I'm going to give you what, all right. So my overdose versus, because in overdoses, we can have fatal overdose, we have non-fatal overdose. And then you could also have something where you just received an incorrect doses of medication.
Okay.
And I think you said to Councilmember Parker that, I think you said something to the effect of, we've had no overdoses, but it is possible that we've had incidents that were outside of best practices. That's what you said, that are investigated. So is a incorrect dosage of medication considered something out of best practice?
Of course.
And is that investigated?
Of course.
And how many of those have we had in the last 24 months?
I don't know. Tell me what period of time we're talking about, and I'll get it back to you.
Okay, so the last
and
24
follow-up
months.
associated with it.
Okay, great. So that could help, because again, I'm like, okay, overdose means something to other people. We're talking about incorrect dosage of medication. In the last 24 months, how many incidents Were they investigated and what were the outcomes? That might help better get to what you're looking for. On that, just as a couple of quick follow-ups, because I don't know, I had a whole crash out after our hearing last week online. So in the last, or 2 weeks ago, and there are a lot of things that, there're just a lot of things, but I just want to follow up on a couple of quick things that you all said that you were working on. So you all indicated that you would soon release requests for proposals for our ophthalmologist contractor at St. Elizabeth's Hospital. That was 2 weeks ago. What is the status of that?
It's moving forward.
You got to turn your mic on. There you go.
It's proceeding. I will get that information for you right after the hearing.
Okay.
That was one of the things on the list.
Okay. I will. I'm going to ask multiple times. And I haven't asked this now, and I'm just going to give you a forecast. I don't know what's going to happen, but I don't know when this new budget is coming. We don't know. I know when it's supposed to be here, but I don't know when she's really going to deliver it. So we might have another status update hearing on St. Elizabeth's Hospital prior to the budget, because I don't think I can wait until May or June, whenever that might happen. Okay. At the roundtable 2 weeks ago, you indicated plans to reopen the TLC unit using a clubhouse model, beginning with approximately 5 patients and expanding over time to support skill building and job readiness. What is the update on that?
It proceeded as we reported it. It was open as described in the testimony.
So it has reopened?
Yes,
Okay. And how many patients are currently participating?
I think 5 were indicated.
Right, we have prioritized hiring at St. Elizabeth, and all of those positions are in play. And it includes the positions, like I said before, our psychiatric nurses, our BHTs, and other staff.
Okay. On that, I believe you said that you have hired or made an offer to some folks in the housekeeping staff. Did I read that right? 4 housekeepers. They're onboarding now. What happened with our locksmith?
Positions posted, we're recruiting.
Positions posted and recruited. Okay. Have we decided whether or not to phone a friend in the interim and ask Department of General Services if there's a locksmith that can help you with current?
We've reached out to them on that and a number of other services as well.
Okay, and they've been responsive or no?
They're getting back to us when they had the services available that we're seeking. It's an ongoing attempt to get resources and support from DGS. It's just ongoing because it's a working partnership that we've established that's growing over the past year.
No, but you haven't had a locksmith for 6 months.
Oh, we haven't had locksmith longer than that, but we're recruiting now to have a permanent locksmith. Now, our locksmith retired, I think, a year ago. Prior to that retirement, we had a locksmith for years.
Okay. I'm gonna let it ride. At the roundtable, you indicated that you were in the process of upgrading the hospital's internal and external camera system.
Yes.
What are the conversations with contracting procurement about the if it's a RFP or an RFA for that?
I checked on it yesterday. It's moving forward. We had a vendor out just yesterday doing a review of the hospital grounds.
So we've selected a vendor.
No, we have a vendor that is out looking at the facility.
Okay, so I guess the vendor is taking a look at the facility to then give you an estimate?
To
Is that-
design,
A
yeah.
proposal. Mhm.
Right, all right. Progress. I'm just specific. Just saying it's in progress is
Yes.
like not enough. Now we gotta
No.
get some sort of verification pieces that are going. Okay, Dr. Bazaran, I've been on the emails with the union about the meetings that are gonna happen every 3 weeks. When is the first meeting scheduled to take place?
I don't know. I just saw the notice coming through that they had agreed yesterday. And so I don't know what the date is. It's been established by the DN. But I
Okay.
can tell you when that is.
Okay, just let us know.
Mhm.
The union did request in their last email that someone from my office or Councilmember Parker's office join. Councilmember Parker's characterization of the deputy mayor may not want us there, which, fine, because we're probably gonna get the readout anyway. Either way it goes, but we want to make sure that those are happening in a consistent manner.
Certainly.
I'm gonna follow up again on the question around the work order pieces and the locksmiths in general.
Mhm.
I don't see why Department of General Services would say no, but I feel like waiting until you're able to recruit and or hire a locksmith to handle some of the locksmith-related work orders at the hospital is concerning. So I'll just leave it there. Okay, we're gonna take a quick 5-minute break, Dr. Bazaran, and then when we come back,
Okay.
Councilmember Freeman will join us for his round. Thank you.
And the beat goes on.
Yes. Okay, Dr. Bazarong, you guys ready?
We'll get that scheduled.
Okay, we're back. Councilmember Freeman, Councilman from Ward 3.
Thank you very much, Chair Henderson. Nice to see everybody. I have a couple of topics that I want to try to explore with you. And one of them, and we've worked closely on this and grateful for your work on this, is the pilot program on Connecticut Avenue, where you've placed 8 folks in 8 different buildings. And I'm curious how you think that's going, how you're tracking the data, any data for that as to get started.
Yes, first of all, I think it's going very well. I think having the hotline has been a real advantage so that the building management can get quickly in touch with the team when needed. The follow-up is very good, and we are collecting data on a monthly report. And Dr. Jean Moise is here, and he is responsible for that program. And so I wanted him to share some of the specific data.
Wonderful, thank you.
Good afternoon, Council Member. Good to see you again. Just yesterday, in anticipation of our meeting today, I asked.
So it's good I showed up, otherwise you would have.
I would have wasted my time. I asked them for an up-to-date report, which I'm happy to share with you electronically after this meeting. I just got it from them through yesterday. So I can tell you the kind of metrics that they're tracking on a regular basis. And if there are additional metrics or different metrics or outcomes you're looking for, we'll be happy to talk to them about including those as well. But so far, and this is not specific to Connecticut Avenue, I know that initially that was our initial kind of focus and surge. This reflects activity across the district, across the city.
Is it similar activity where
Yeah.
there's some, and so how many buildings now across the city are you doing this in?
Let me see. I can get you that. The 8 buildings is on Connecticut Avenue. We know that, but I think he's asking about other buildings across the city.
That you're doing the same thing in?
Yeah, I can get you that.
Great.
But what I have is from them is the total number of calls to the hotline is 151. And that's mostly from property managers and landlords inquiring and requesting for care and support for the residents. Remember, we've also shared a flyer that we're posting in many of these buildings where we've had any contact, so people know that that service is available so they can call in when they need support or assistance. Total outreach and engagement, that's with unique residents that have either been identified as needing support or in one way or another that we feel could benefit, is 1,119 since May to date. That's actual contacts and engagements with an individual resident within the buildings.
And you
Unique
said
individuals.
unique residents, so it could be multiple contacts with one person, but
Right,
it's 1,000
yeah,
people that you've
right,
had contact with.
Correct. I think that's a more significant measure than 500,000 contacts with 3 people. Reconnections to community service organizations is 47. People that either could benefit from a relationship with an outpatient community mental health provider or who have been involved or engaged in the past who are disconnected, getting reconnected to care basically as part of the plan, 47.
So that's 5% of the 1,000 people who you're in contact. Some of them might have a care provider, so it's not necessarily,
But these are reconnects. So if somebody's already in care, we're not counting that.
Right.
It's people that we're reconnecting or initiating care back with a community service provider.
okay, keep going.
People that for some reason or another needed to relocate to a different apartment, they assisted 24 people in that circumstance. Linkages to other resources, social determinants of care, transportation, phone, food, utility assistance, 169. Landlord coordination and mediations in a very broad, loose term, not a legal, mediation, but 23 such instances where we sat down with the property owner, not we, me, but the provider, sat down with the property manager and the resident to sort of mediate or mitigate whatever the issues are. And then crisis interventions where people were referred to an emergency level of service outside of our scope of service, like CPAP or a hospital, was 26.
One of the things that I'd like to say is I think a part of the benefit of this particular program is that the staff who are providing the service really have worked to engage the property managers and to have routine meetings with the property managers so that when something comes up, they will get a call before it gets to the point where it's such a crisis that it might not be able to be dealt with. And so I think that's important. The hotline here again, I just think that's also critically important because then with that hotline, people from across the district can certainly call and get support.
So really, really appreciate it. Also, grateful that the idea that Connecticut Avenue might be a pilot, but that it has spread to other places. I'm going to be very curious to see what those numbers look like. A metric that isn't within your control in the same way is, and I don't want to equate these issues with the only reason why there were police calls at buildings is because of these kinds of things, but some of the mental health breakdowns in various buildings have led to lots of different police calls. So I wonder if there's data out there about any change in the number of MPD calls to buildings. If you took the buildings that you've been working with and did a comparison 1 year over year, what that might look like.
That's certainly outside of our scope, meaning DBH, but I know that's a metric that when there've been two, as you know, meetings with the mayor's office around this, especially around the Connecticut Avenue buildings, and that data had been pulled for those buildings, Connecticut Avenue buildings. So we didn't pull that data, but they were available in the meetings to look at the historical trends in terms of police calls or emergency calls at certain buildings over time. So now if that could be done for the buildings that we're engaged in, either on Connecticut Avenue or others, we could look at the trends and comparisons over time.
Right. And the other thing that you brought up, council member, is the fact that every incident is not related to someone's mental health status. Also, we received information directly from members of the community that a lot of it also had to do with child welfare related issues. And so we have to work together, and we have with CFSA, and we are, in terms of how we address both of those issues.
100% with you. And again, tried to premise the question on, it's not a one-to-one thing, but
Right.
if this were working well, one would hope to see at least a marginal decrease in police calls.
Of course.
And so that's a thing I want to follow up on. So let's do follow up. I'd love to get that data electronically, love to track that data going forward, and love to know what's the full list of buildings that you're doing this at, because, so thank you for that.
Sure. Thank you.
Everything takes longer than I thought, so I'm gonna wait till my next round to ask you about PIW. But we looked through the combined block grant plan where you had an application, and one of the things that you had said in there was that I'm going to not use the exact right word, but a weakness or gaps in our ability to serve youth homeless. And
That's
particularly, so can you speak to what you're getting at when you talk about that?
Well, first of all, we know that there are youth who are out there on the street who are unhoused. We do know that is a gap in service, and we may need to have a specially trained team to work with those young people, or we may need to have another special facility. Like, for example, I can give you an example. In Pittsburgh, we had a special, it wasn't a shelter, but it was a place where young people who were living outside could come, they could shower, they could pass through, they could get some supports and so forth. And that kind of was very useful. And we found that with that, we were able to then connect those young people to the services they need. But it took, here again, that engagement over time. And it may be that that's something that we need to think about for here. We don't have that specialized service here, and so it is a gap.
Well, how does that differ from, for example, the Sasha Bruce Drop-In Center? Doesn't the Sasha Bruce Drop-In Center, doesn't that,
Dr. Bruce.
yeah, doesn't that play that sort of?
Play some of that, yeah.
So is it that you would like to see something like that strengthened? So
Absolutely. Strengthened so that it can handle, more young people, and also so that we had, I don't know, for example, and I'm just speaking out loud here in terms of my own thoughts, and that is that should we have outreach workers that are working within the outreach teams that are working with the unhoused population who are particularly trained around youth-related issues and youth-related engagement activities?
so
So,
that,
some other supports.
so, and I'll stop with this, Chair Henderson, but I guess what I'm hearing is there might be the youth drop-in centers and they may be doing good work. And I do think Sasha Bruce has
Sasha
done.
Bruce is wonderful.
Okay. But there might be more of an interface with your workers
Exactly.
to seize the moment when the kids are there, if there are issues that arise. Is
So
that
we
what
can
you're
get
talking
them
about?
into care.
Okay, thank you very much.
Chairperson Henderson, can I just make sort of a follow-up comment on your statement earlier about the case that was raised, was that just Monday, a few days ago?
Oh,
About the
sure, yeah.
property owner and related to the Housing Support Care Management Program.
Okay.
I believe your staff have heard from MBI. The assumption was that the property manager was calling the hotline, the Community Connections hotline around this program. We've discovered that was not the case.
Okay.
What was happening is because they believe that resident had history at MBI, they were calling MBI's clinical service hotline. So we were never notified and Community Connections was never involved in that case, never responded to that case. But since MBI has let me know that they've attempted to engage that individual and he is not interested in treatment, no matter what his circumstances are. But I've also asked Community Connections through the Housing Support Care Management Program to continue that engagement, to try to build a relationship with him to see if he would be more amenable to treatment down the road. But just wanted to clarify, they said they were calling the hotline.
Yeah.
It wasn't this hotline, it was the service hotline at MBI.
Okay. I think that, Ashley, you could start my time because I'm going to ask some questions about housing, but I think that sort of speaks to the overall, how we are promoting the hotline for folks. Obviously the larger buildings, the larger landlords, no, but for some of the smaller unit facilities, just so that they know that they're calling the right person and not having this feeling of, I've been reaching out and nothing has happened, which was obviously came through in that particular testimony as well. And I know, Dr. Bazaran, you often talk about consumer choice and everyone having choice. And I just fear that in that particular situation, given some of the incidents that were described, like there's going to be a law enforcement response as opposed to a public health one. If there isn't an intervention there. So, but I'm glad it's now on our radar. Okay. I wanted to ask, sort of following up a little bit of what Councilmember Furman was talking about in terms of young people. Wayne Place served a small number of transition age youth, and it had positive outcomes in its program, Wayne Place. And I'm curious whether or not you all have plans to expand or replicate this particular model.
Well, first of all, Wayne Place is one of the services and supports that I think we need to maintain within our community. And one of the things that we have done is we've looked at how we might use the transition to independence evidence-based practice, which is the kind of the platform that's used for Wayne Place for other populations. like for individuals who are involved with DYRS, those involved with CFSA, as well as those with mental health and substance use problems. And we do have services going there. We plan to maintain those services and use it as step downs, particularly for individuals who may have been in a psychiatric residential treatment facility, coming back to the community, or stepping down from DYRS's facility so that they can really begin to make that plan.
Yep.
to move
So my
on.
question still is, do you all have plans to expand this particular model?
At this moment, we don't have plans to develop another Wayne Place.
Okay.
We need to use the one we have.
Okay. I want to ask about landlord payments and the sort of vouchers. I won't go into far depth because we did have a hearing on behavioral health vouchers a couple of months ago, but what's the process for stopping payment on a voucher when a client has died, they've vacated the property, they've left, et cetera?
The staff managing the voucher program are often immediately informed or made aware, and we terminate the payments and try to get somebody else into that apartment who may be interested in that situation.
How long does a person have to be vacated from the property before you all determine that it is, like, that person is not coming back?
Complicated question, because people can, based on their circumstances and their level of need, sometimes may wind up going to a hospital for
Right.
physical or
Mhm.
behavioral health needs for a week or 2 or 3. So we sort of assess that on an individual basis, based on the circumstances. If we believe the person's died, obviously, or have evidence of that, or left the area.
Yeah.
And we're notified pretty quickly because we're tracking vacancies very closely, then we'll act. But if the person's in a transitional kind of situation, we may wait several weeks until we determine what's in their best interest.
And it's
Okay.
the hospital or incarceration.
Or incarceration.
So the committee received a complaint from a DBH employee whereby the individual who received the voucher, I believe, was dead, died in February of 2025. We continue to pay. And the landlord, out of the kindness, I don't know why, but the landlord then decided to alert DBH of, like, hey, that person no longer lives here. And yet we continue to pay even further. When the staffer alerted their manager, they were essentially reprimanded? Reprimanded. The staffer alerted their manager, hey, we've been paying and that person is dead. They were reprimanded by their supervisor.
I would appreciate getting the name of the supervisor or the case so I could look into it. That's
Okay.
news to me. That area reports up to me, and it's really the first time I'm hearing this.
Okay, as my big concern on that was that had the landlord not reported,
We wouldn't have known.
you wouldn't have known, which kind of goes counter to what you were saying, Dr. Moise, if you guys do
Sure.
ongoing monitoring
Yep.
of someone being in a unit versus not. So there's some control that's sort of falling off,
Yep.
which is different than someone vacating a property, right?
Mhm.
Person's no longer alive. So we'll follow up on that as well, and we'll go from there.
Thank you.
Okay. There was testimony earlier this week, and we're going to do a hearing on CRFs, but we had 23 closures of community residential facilities between FY23 and FY25. There are already 8 anticipated for this fiscal year. When you all have providers who decide to close, are we asking in some ways, I don't know, an exit interview? Like, what's the reason? Is it staff? Is it our reimbursement rate is not doing what it needs to do? Like, what's the reason?
Absolutely, yes. That is a very important factor because the trend has been over the last few years, we've had less capacity in terms of in the system than previously. So we do have very deep discussions with the operators, and there are numerous reasons that we've determined apply. One is many of these folks have been in the business, that line of business for some time and are getting older and it's challenging and they want to get out.
Okay, retirement.
Retirement. A few times people have died relatedly because they're getting older. Some folks wish to get out of that line of business because they feel the reimbursement is not sufficient compared to the opportunities that the market offers to sell the home and, you know, make a profit.
Right. There was testimony that our reimbursement rates are 40 to 60% less than Maryland and Virginia. When is the last time we've done a market survey of our reimbursement rates?
Are you talking about vouchers versus CRFs?
I'm talking about CRFs, like
Okay.
the
We provided a 19% increase to our CRF operators in 23.
in 23.
23. I can't speak to, at this time, how that rate, that current rate compares to Maryland and Virginia myself right now.
Okay, so 23 was the last time we looked at it? Or 23 was the last time we gave an increase?
Last time we gave an increase.
Okay, so when's the last time we looked at it?
It's 23.
All right. Ms. Jackson?
Yes, I wanted to add a minor clarification. When I heard the testimony about the comparison between our rates in Maryland and Virginia, I believed it was an SUD residential provider talking about the per diem rate for room and board.
That was there, but there was also a conversation with some of the folks who testified about CRF who also said that our rates were less. So that's why I'm asking. I know you know, we've long heard from our residential SUD folks that they don't believe that we're paying enough.
Yeah.
But on CRFs, I mean, you know, do we regularly review our rates on CRF on a cadence?
We can do that moving forward. The challenges have been our, you know, available funds to give.
I know, but a review doesn't mean we're gonna
Right.
give it to you. A review determines whether or not, how far we are behind.
Yeah.
A review is a
Absolutely.
benchmark. It's not a, you gonna get this. We do lots of reviews.
Councilmember, we haven't done it since 2023, but that's something that we can address.
Okay, I feel like when we have situations where we have a lot of providers who are leaving a particular market and it's decreasing our overall capacity, that requires us to take a look at
Sure.
what it is. We had this happen on the Medicaid side, right? We have a lot of dental providers who were leaving the Medicaid program because the rates had not been increased in nearly 12, 13 years. That forced us to deal with that immediately. But in the same way that I said to Director Turnage and his team, if it's on a regular cadence, not that you're gonna get the increase, but that we're just looking at it, that allows for us not to have to make a 19% increase in 1 year. That tells me that we had not been keeping up in the years prior, that we had to do nearly 20% in a year. I'm over my time. Councilmember Freeman?
Thank you very much, Chair Henderson. First, a couple of questions. In your testimony, I think you referred to 38 people have lost Medicaid benefits and 227 people have lost Alliance coverage. And I guess I just want to make sure that I properly understand that. That is not the total number of people who have lost Medicaid or Alliance.
No.
Those are the people who you serve who have lost Medicaid or Alliance.
That is correct.
And then for the things that you do, you then try to connect them with other services. What happens? What's happening in those settings where somebody's lost coverage?
Well, first of all, we work with their core service agency, and we have identified those individuals who are in that bucket where they are either over income or don't qualify for some other reason, and ask them, the core service agency that is providing the care for that individuals, to work to connect them to other services if appropriate. As I said earlier, if that individual is seriously and persistently mentally ill and meets the Act requirements, we will continue to provide those services using our local dollar allocation, irregardless of their status.
So, and for those people who are not that acutely ill, but lost coverage and had serious enough issues that they were getting your services before, what are the options for them that the core service agency may direct them to?
There are, do you want to? We can both. Okay.
Sure, there are a number of ways for them to get information on whether or not they can join the Universal Health Benefit for DC, which is managed by the managed care organizations. And there have been trainings and presentations. We had one at our monthly provider meeting at DBH, where all the providers attend about what those options are, along with the listing of sessions that were going to be held around the district to help people access those services. And then the other option is to access through the health benefit exchange.
Okay, so, I mean, these are not giant numbers, but they're bigger numbers out there of people who are being disconnected from benefits. And the big question for us has been, how are we doing at connecting them to a fallback? What does it look like for you? If it's 38 and 277, that's something like 325 people who you may have been trying to help. How many of them do you think you've been able to help to connect them to some form of service so that it is not that they fell off a cliff?
DVH doesn't connect that. Our provider network would work to connect them, but have had trainings on how to make that connection. The thing we do is work with the provider if in the 38 that I referred to is the change in people accessing behavioral health benefits that previously had Medicaid. So, I mean, that just happened January 1.
Right.
And so one of those people this last week, we worked with the provider. They were in ACT services. So we have now signed them up for a 180-day period for ACT services using local funds.
So I hear you that it's the provider network that's doing this, but do you track it? Do you try to follow up so that you know to what extent your network has been successful at connecting people to fallback services?
Yes, as you know, some of these events have just started to happen, and so we can track that. We can follow up.
For us, I mean, there are changes that we made in hopes that they would be a safety net, but are they a safety net?
Right.
So help us to understand that. On the Psychiatric Institute of Washington, a year ago, I think we were here together, and there was a lot that we had to talk about around the Psychiatric Institute of Washington. I'm curious how you see it going today compared. I mean, this is a challenge, and I will say, and I probably said this before, there was a time where there were a lot of issues on the street in front of the Psychiatric Institute, and those issues were largely addressed. But then, and so it sort of went off my radar screen, but then there are issues inside of the building. Last year, we heard a lot of concerns about things inside of the building, and I think, I mean, that's absolutely critically important. So what are the trends, and what are you doing to provide strong oversight of operations there?
Yes, council member, as you know, we enhanced our oversight of PIW. We are not the licensing entity, that's DC Health, but we do have responsibility for those individuals who go in there with psychiatric concerns. And so we now monitor very frequently. Every 2 weeks, there's a site visit. We collect data. We actually look at the treatment plans for the individuals who are placed there to see whether or not that looks like it's effective. And that has really made a difference in terms of the care that people are receiving. We still, however, do have some issues related to youth and how youth are accepted. And I'm going to have our Chief Clinical Officer, who is intimately involved in that, to speak to some of those issues.
Thank you, Councilmember, for the question about PIW. Dr. Bazrod is correct. We have limited oversight of PIW because it is a hospital. DC Health is the one that regulates it. We do provide supervision and oversight for those particular consumers who are who go in, who are involuntarily admitted. So we do have our Care Access Innovation Team. We actually have one person who is dedicated to just PIW, who actually reviews the notes, who is in contact with their discharge coordinator, social work. So we work very intimately with PIW in regards to the patient care that is there.
Is that something new, or is that a thing that's been going on for years?
It's been going on for years, and I've been here for 3 years.
I actually had hoped it was something new because we had issues before, and so I hope.
No, we had somebody doing oversight, but the oversight was not, as for the frequency, was not what it is now. We've ramped it up significantly. We had someone, but maybe once a month they might go. But now we have them in constant communication. That's their job.
Okay, I interrupted you, so you.
So we are definitely aware of some of the issues and deficiencies, and so we're working with the folks at PIW through our various teams to make sure that these deficiencies are addressed. In particular for youth, we recognize that there have been some challenges. Sometimes when it's time for a person to be admitted there, sometimes they will not accept some of the youth. And so we're working through some of those challenges in regards to how they admit.
On what basis do they decline to admit?
I'll just use the word discretionary.
What's that?
Discretionary reasons.
Discretionary. I mean, this goes to, I think Chair Henderson, I think, has said before, you get into a world of too big to fail. When I look at the numbers, we don't have a lot of options besides PIW. So if they say no, where do we go?
You know, sometimes children's will accept, but again, you know, it's very limited, as you said, options. And so we're really, you know, down to those two options. If one of the two do not accept, I mean, we've run across some very real cases DBH has been involved in. And we have really utilized our resources and staff. We have some that are court-ordered youth to go in for admissions, and they will refuse. And so DBH is held responsible for these youth, and we go above and beyond to make sure that those youth are taken care of.
Okay, I've run out of time. I actually thought I was going to do one round. I'm surprised I did 2. Now I'm going to do 3. Thank you very much.
Councilmember Freeman, the issue that they discussed in terms of PIW, it has been one of concern that has been raised, especially with DYRS. A number of times we have not been able to fully reach a resolution, but we make progress.
Yes.
Okay. We have to go faster because there's another hearing in this room. So I'm gonna try to move as quickly as possible. All right, I want to talk about harm reduction really quickly. Harm reduction. So the data shows a significant variation in the number of syringes distributed and collected across the vendors. Some are more than others. How are you all evaluating vendor performance in terms of both impact, but also community cleanliness and relations?
You want to take it?
We pay very close attention to that issue. We have 3 syringe support programs and providers. One being HIPS, which is the one that's most active in this area.
Yeah.
I think, you know, the rate of distribution and collection dropped in '25, but we're working together to try to increase that
Okay.
effort, because we agree that that's a very, very important component of prevention in the community, given the continued ODs that we have out there. Because of the federal policy changes, we've had to make a change over the last several months to redirect the dollars that we were granting directly to those providers. Now those dollars are being routed through DC Health because that wasn't permissible within DVH. So we still have a commitment. We're trying to ramp up the rate and trying to make sure that we turn around that trend.
Okay, so there are 3 vendors, as you said. HIPS, yes, outsized impact. A little bit different. I put HIPS in its own little category because they've been around longer, also more well connected within the various networks and community. You have one of your vendors who, didn't report that they collect any syringes for October and November. Literally 0. In comparison to everybody else who have done a healthy amount. So, I feel like in parts of our government, we hold on to vendors because we hold on to people. Like, we don't ever want to let somebody go. If you are not performing, if there's some sort of problem, even after we've tried to do a corrective action plan, I'd like to get our money's worth.
Sure.
And I don't know if we're doing that. Is it a location problem?
Chairperson, I'll have to admit that I wasn't aware of what you just said.
Okay, this was in the
What's up?
pre-hearing responses, so this is in the pre-hearing responses, so this is what you guys sent to us.
I will follow up with my team and give you an answer
Okay.
to that.
Now, it says that you guys assign the vendors geographic areas, but you might also reassign them based on hotspot data and community concerns. How frequently in a year are you all changing geographic areas based on the data feedback that we're getting?
It's a constant effort. We're meeting with them all the time and we're getting that input and feedback from them, and they drive it because they're the ones on the ground, and we're trying to make sure the distribution is is focused around the city as appropriately as possible.
Okay, I feel like one of the worst things that we get on this side of a council member is when we get someone from community, they're like, why don't you guys spend money to do X? And then I'm like, we spend lots of money to do X, but somehow it just isn't making it to where it needs to be. These are one of those types of programs where I don't necessarily feel like it is, you don't have to be licensed and it's not specialized, right?
Sure.
So we're looking for people who have, you're in community. You have workers who want to be in community, who are observant, who are connected with businesses and schools and otherwise. And yes, may be able to establish some relationship with some of the individuals who may be using. But right, we're not looking for somebody who determines a license. So this contract in my mind shouldn't necessarily be sacred. We should really be trying to move on that.
And we have the same philosophy and value as you stated.
All right. Now, I think one of our shining spots, Dr. Bazaran, in sort of our work around SUD has been our naloxone distribution. I would tell you that other jurisdictions, colleagues who work in other jurisdictions are very jealous of what we have been able to pull off here in the district. And I think that has helped in some ways, and some of the numbers that we have seen. Even though our fatal overdose numbers have been dropping, our non-fatal overdose number is on the rise. Now, I say, okay, yeah, we're keeping you alive, but now you still want the thing that is could potentially kill you. And so let me ask a couple of questions. One, how are we assessing our naloxone availability, in particular hotspots, overdose hotspots? Like when we're seeing spikes in particular areas, is your outreach teams going out to say, all right, let's put some more, in community around these areas?
Yes, absolutely. We do focus on hotspots. Our naloxone supply is more than adequate.
Okay.
And we distribute it freely. And providers come and pick it up, or we take it to communities. And so that's well in place.
Okay. What does training look like with our partners in MPD? who unfortunately are often they are the first responders on some of these cases. Like, how frequent does it happen, or who is the one who is administering some of the training?
I don't know how frequently it happens, but I know that it is available in terms of, how you administer naloxone, for example.
Yep.
Which is very, very important. We also have that, there's an electronic tape, I believe, that we have in terms of how to administer naloxone. But I don't know how frequently we do an actual training with MPD.
Okay,
I just don't know the answer.
I have a meeting this afternoon with the interim chief, so maybe we'll talk a little about this. But because MPD might be the first responders that normally are on, it's very important that they know what to do.
Absolutely. Yeah.
And I think even more so important that they recognize like the swiftness with which you have to act. I had 2 situations last year, one where I had to call 911. And, in some areas where there are hot spots, I feel like there is like this numbness of community where they're like, oh, this happens every week. Community members are over it. And I worry that is translating to some of our officers as well. And sort of, it was just like, this was a regular day. And I'm like, that guy is not breathing. And I don't have anything on me. And my car is like down the street where I do have, naloxone in the car. And so I just feel like we need to tighten up just a little bit, particularly in the areas where we do have hotspots. And this is in Columbia Heights. Some of this will, resolve itself with this, not resolve itself. The stabilization center might help in terms of some of the community interaction pieces, but all first responders, not just on the FEM side, should know, the protocols here. Okay, at the federal level, there's been some recent changes to the guidance and enforcement around harm reduction. How are you all sort of tracking these federal changes? I know sometimes it feels like whiplash, like you get a notice one day and 24 hours later, the feds are changing their mind. But what processes are you all taking to be as communicative as possible with your grantees around what are now allowable activities versus not?
First of all, as I said earlier, one of the things that I personally do is I meet with the other commissioners across the country in a meeting that's sponsored by the National Association of Drug and Alcohol Abuse Directors. And through that, we get information in terms of what's coming down from the Hill, what the changes are, and then we talk together about how we can approach it. And as you know, we've had some whiplash, where we, on a Tuesday night at 11 o'clock, I got a message that X number of my grants were just canceled. And there was no appeal process. And so we immediately then had to go into action, notifying providers to stop work immediately, letting them know what would happen. And then that next night, I got a message that said, oh, you're reinstated. Don't worry about it. And so, we have to, one of the things that is important is we have to stay abreast of it. That's why I stay and pay attention to that. And then the other thing that has happened is that with the change of the assistant secretary, there were significant changes around the definition of harm reduction that was allowable. We had to literally go through every single one of our grants and change language to be consistent, to ensure that we could actually draw down the dollars that we were given. And we did that very quickly. The second thing.
Well, can I just ask as a follow-up to that, though? When I look at the budget in terms of how we spend on harm reduction, and I recognize that I'm over time, and I got 2 colleagues who are waiting, so I'm going to be very brief. Most of the harm reduction funding that we have, at least my understanding of the budget, is federal. Have we thought about perhaps we need to make some shifts such that if the secretary wakes up one day and is like, yeah, I'm not feeling harm reduction in any forms, the district is not left with nothing.
Yes, as a
Okay.
matter of fact, we have. And one of the things that we've done is we have actually put the opioid abatement fund and the SOAR fund under the substance abuse umbrella in a tighter match so that we can, in fact, as you know, opioid dollars are much more flexible. If we need to shift, then we can do that fairly quickly and easily and then move that. As you know, local dollars are tight. And so we're trying to look at every potential availability we have to support that so that we can plan appropriately. And
Okay.
Dr. Melish, you may.
Oh, no, I'm over my time. I'm sure we'll talk more about this at the budget
Yeah.
process. Councilmember Parker?
Well, thank you. I wanted to talk about the Juvenile Behavioral Diversion Program. And you provided some responses in your pre-hearing questions that I want to dig into. When youth are found to be legally eligible for the program and a referral is issued by the Office of the Attorney General, how long is the process for a youth to be entered into the program to receive treatment? So once the referral has been received by you all.
Introduce yourself.
Good afternoon, Dr. Chad Tilbrook, Director of Forensic Service Division at DBH. Thank you for that question. The short answer is that it varies. It varies quite a bit. Oftentimes, as noted in the information that was provided prior to this hearing, is that the OAG is often the determining factor to determine eligibility from a legal standpoint. And so they're often the ones that are the first determiner, the first decision maker about eligibility. After that, the case goes to a suitability committee. And at the suitability committee, there's multiple partners that are available who weigh in about
Who makes up that suitability committee?
quite a number of agencies, including Court Social Services, DBH, obviously, and Child Guidance Clinic. So there's a number of partners that are available, including the core service agencies that would be providing the services. So there's a number of partners who are at the table who discuss the case to determine the feasibility of actually delivering the services that this youth needs in a timely fashion that is in accordance with that diversion program.
Understood. And I'm happy to see the low recidivism rate data. This is down from 24% the year before, so moving in the right direction. What would you attribute this improvement to?
We're also very happy to see that also. It's been the teams that have been working in this sphere have done a tremendous job working with a very challenging population. One of the challenges that we continue to see, and this does address the question, is not only meeting the eligibility, but also getting the youth to buy into the program, the families to buy into the program, because it is a voluntary program. So that is one of the biggest challenges that we have is to—
It's voluntary to an extent. It's voluntary, yes, but also there's an agreement that a young person isn't going to be sent down another route because they're going to be in this diversion program per the Office of the Attorney General.
There is a carrot.
Yeah.
It's not a big enough carrot for some youth. I really believe that some of the youth are daunted by the commitment that this program takes, because sometimes the commitment to these diversion programs is greater than what would result in a plea deal and a sentencing in a short period of time in DYRS custody or some other types of delinquency.
Understood.
Punishment.
And this is, you're going to need to follow up here, but for fiscal year 25 and fiscal year 26, can DBH provide a breakdown of the participants of the program by status of the offense and case outcome?
Yes, we can follow up, but it's going to take us some time in that the recidivism rates that we are looking at are a calendar year behind. So our metric for determining whether recidivism did or did not occur is 12 months after the completion.
I see. Okay. But for the data that you do have, what I'm trying to get at, it would be helpful to get a sense of the outcomes for these young people, but also why they were in this referral program to begin with. Are we talking about someone stole a bag of chips? Are we talking about someone that's committing armed carjacking? I think just more information is going to help us know who are the participants as we're trying to problem solve. What criteria are used to determine which participants receive the services? And I think you talked about that. That committee is what decides the services that those young people are going to receive. Let me go here because my time is ticking. How does DBH interpret the variation in recidivism rates across enrollment years, particularly the higher rates observed in 18 through 2021, and what factors you believe are considered when you all are planning for long-term success? And what I'm getting at, and I'm going to give you time to think of it, what I'm getting at is, to me, when I saw the numbers decline in the way that they did, I said, oh, this could be a critical lever for the district at a time when we're talking about juvenile delinquency. Here's a program that maybe is working, that we should be talking about more or touting more. And so I then had all these follow-up questions thinking about, well, how might we scale this or promote this in partnership with the Office of the Attorney General for more of our young people that may be on the wrong path?
I think I'm really appreciate your interest in this program, and I'm happy to take it back to my team if we can do a deeper dive into some of that trajectory and eligibility criteria that may indeed make such a difference, as you pointed out. Expanding this program, I think, would be a huge benefit to the district and to the youth that really need these services. It offers them a great opportunity, not only in the immediate term, but also the long term. And that's what really, us as in the public health sector, really care about. So I really think we should take this back.
And how would we expand the program?
Well, we could expand it by, and this is my view of this, by expanding eligibility criteria. So for example, OAG has their criteria about who would be eligible and not eligible from a legal standpoint. I think we could go back to the table to determine whether there should be more offense types that could be included for legal eligibility.
Or maybe some young people that have not yet encountered the OAG, but we want to get to before that.
Absolutely. I think that not only JDBP is an option, but there
You're
are
giving Dr. Bazaran more work, but I think that's a great idea. I think we should be thinking creatively about juvenile delinquency, and I certainly think DBH has a role to play there. So I would love to work with Chair Henderson and you, Dr. Bazaran, to think about what might that look like in terms of expanding this program, because we are seeing success per your data. All right, I know I missed some of Chairperson Henderson's questions. I will just use my last 2 minutes to talk about opioid use reduction. Where are things with the Ivy City opioid reduction area? There was a partner selected. I'm blanking on the name. Us Helping Us, I believe, was the partner. The reduction area. You're looking at me puzzled. So there was a grant secured from this committee to have like opioid reduction sites, and Ivy City and Ward 5 was one of those sites.
The substance abuse targeted outreach grants.
The way, oh, the outreach,
Targeted outreach grants.
oh yeah, for the outreach grants. Okay, I wasn't.
Yes,
tracking
no, I know.
what you
I
were
can tell by your
saying.
face. You're like, what are you talking about? So
Yeah.
what is the status?
The outreach grants are being implemented.
But how are we monitoring success? What
Right.
progress are we
You're gonna
seeing?
have Dr. Melise come up and talk about that, because he knows. We do have those grants being implemented.
Yeah, our team's in close contact with them right now, the providers. I'll have to get back to you with that.
Generally speaking, are we seeing progress? Is it
I
working?
think-
Is it
I
worthwhile?
think our conclusion is that the providers are being effective and making a difference in
Okay.
executing our goals
And that's across sites.
across the sites. I'll get back to you about Ivy City especially.
Okay, that would be helpful. And I only have 1 minute left. I'll just end with this. And it's kind of what I was just talking about with the juveniles. I think, again, DBH has a big role to play in many of the challenges that we're seeing play out in the district. And I just would look forward to working with you, Dr. Bazaran. I am heartened to hear about the work that you're leading, trying to address some of the concerns with St. Elizabeth's in particular. I'm going to schedule a visit, but would welcome regular updates as much as you can share following those meetings. I won't come, but following those meetings, I would love to hear that. And I'm also thrilled to hear the progress we're making with the school-based behavioral health program, as I know that's been a pain point for several years. So
Thank you.
Thank you. Thank you.
Thank you, Councilmember Parker. I'll just mention the vendor that you said. That's the vendor that I think is underperforming on the other thing that we just talked about.
Okay.
Councilmember Furman.
Thank you very much. I'm going to go back to PIW, so I don't know whether we can have you come rejoin. One thing, big picture, I'm curious, how much does it cost to have somebody go to PIW? How much does it cost the district?
Do you mean for treatment?
Yeah.
There is we do have a daily rate, and I can share that information with you that we pay when somebody is on FD12 status and goes. But I don't know, Dr. Shepherd, if you have that at the top of your.
I don't have that information.
But I do, we have a daily rate that we pay, and it's a negotiated daily rate. And what we do is that rate was established in partnership with Medicaid so that it is consistent with their Medicaid daily rate.
So is it Medicaid dollars or is it our dollars?
No,
It's our
it's
dollars.
our dollars.
The reason that I brought it up is I have a feeling that number's high. And so then there's all of these other preventive things that people talk about. And I think one could view the investment in these preventive programs partly in the context of this could be an avoided cost if we can get to people sooner so that they don't have to be FD12 to PIW. So, but back to the incidents. So there's a table in the pre-hearing responses of the incidents that happened at PIW. There's different categories of incidents. There's I think it's the unusual incidents, major unusual incidents, and then there's a category that results in an investigation that might be abuse and neglect. But help me understand what the breakdown of the incidents are. What's an unusual incident? What's a major unusual incident? And what is it that gets you to where you would expect an investigation and a report back of that investigation to come to you?
I think maybe it's.
Hold on, I see yes.
Forgive me. I thought we were on PIW, so. Can you restate the question? It was about the.
It's about PIW.
I know, and that's.
Yeah,
That's
so
what we started with him,
in PIW, in the pre-hearing responses, there's a table that shows the number of incidents. And
okay.
that number of incidents, it was 139 in FY '24, it was in the 500s in FY '25. I think you guys expressed a theory that they were better about complying with their reporting requirements. In FY '26, it's 90 so far. But then there's incidents, but there's different categories of incidents. There's unusual incidents, there's major unusual incidents, and there are incidents that may require an investigation, which the way that I am hearing it involve abuse and neglect. But can you help me understand the difference between the kinds of incidents to start?
Yes. Okay, so the main category we really are looking at is the major unusual incident. We have a policy, I believe it's policy 480, that details in great specificity what is a UI and what's an MUI. So for example, it could be a facility issue. It could something as serious as a fall. It could be fraud, waste, and abuse. Those are all major unusual incidents. The unusual incident is something that the reporter wants to document, but may not rise to the level of that definition. And also per our policy at DBH, unusual incidents that are reported, the person who reports it is supposed to do a follow-up, an investigation, and provide that to the agency. Then the agency determines whether we need to take a second look. Was this investigation thorough? Did it cover all of the salient points of the incident? And we go from there. As Dr. Bazaran mentioned, when she, maybe on the first or second round, we, DBH, are not the licensing body. So when incidents are major, unusual incidents are reported, we share those with DC Health. DC Health is the lead on investigating incidents at PIW.
Yeah, so the table, 139 in 1 year, 569,
That's
90.
reported to us. Mhm.
Yeah, that's in your response. Is that unusual incidents and major unusual incidents, or is that just major unusual incidents?
I believe that table is MUIs, but I will confirm and report back to you.
Okay, because those are the more significant things. So I am curious about that.
Yes.
Also, it's FY20, there's data for FY26, and that's 90, which looks good, except for when it's only, when was that data pulled?
If it was for our oversight questions, it was pulled this month. So it would be FY26 today.
This month, February.
Oh, yes, it is.
January.
January.
Okay.
January.
January.
So then if it was 3 months worth of data for FY26 and you would, if you project it out, it could be at the end of the fiscal year 360. That's still high. And then there's a reference to DBH did not receive any investigation reports from PIW in FY25 and FY26 to date. So that puzzled me, because is the idea that it was 569 maybe MUIs and in FY25 and 90 so far in FY26, were there no what kind of follow-up has happened on that? What if you haven't gotten any investigation reports, why wouldn't you get any? What are the odds that none of them merited an investigation?
So I don't gamble. I'm not going to play those odds. All right.
I
But
did that to you by saying.
Very good question. And it's a question that was asked and answered in the previous hearing with PIW. They've had ongoing challenges with their risk management staff and maintaining risk management staff that meets the basic minimum standards of completing investigations and reporting. So I think it is a issue for us to follow up on with our partners at DC Health, because while not all 500 would warrant a full investigative report, again, the odds are there should be at a minimum 1 or 2.
I mean, certainly at a minimum 1 or 2. I mean, we get anecdotal reports about violence between residents, violence against employees, sexual assaults. It's that there are none is troubling. Okay, I'm going to leave it on that note of being troubled, and we will continue to try to stay on to make sure that that institution works the way it should. So thank you very much. Thank you for your testimony. Thank you for your work.
Thank you.
Okay, Dr. Bowser, we're not there to land the plane, but we're gonna be there in about 20 minutes, okay? So just stick with us. All right, the pre-hearing responses reported that there's a 3.5 level SUD residential treatment facility that's now open for young people using opioid abatement funds. What's the facility's capacity and how many young people have they served to date? 8.
The capacity is
16, yeah,
Capacity
2
is
beds.
16.
Oh, hold on.
Two
You're
referrals.
gonna just put your mic on.
I'm sorry.
It's okay.
Capacity is 16. They've had 2 referrals since opening.
When did they open officially?
November.
November.
I think.
Okay. Is the low number of referrals a reflection of maybe that other providers don't know that this is an option?
Yeah, I think, we're working hard between Children's Services and SUD. Adult Services, it's a combined effort. And so really working also with the provider to get the messaging out. So we've done some messaging at like Children's Roundtable, as well as CFSA, DYRS, and are continuing to reach out, as well as the provider is as well. So it's early on, obviously.
Yeah.
This is something that we've all talked about for years.
I also don't want to have 16 people in there on day
Exactly.
one.
Exactly.
Ramp up is nice, but also we want people to know that this is an option. At the public witness hearing, we heard from Children's. Dr. Rob, who is the chief of pediatric psychiatry over there. And she talked about the increased number of patients that they are seeing coming into the hospital with substance use disorder. And, one of the things that I kind of mentioned to her, and I'll ask this question to you guys too, I know you're not the public health agency, so doing sort of the push out of the public health and the PSA announcements, I know that's more of a DC Health, and I'll certainly ask DC Health this, but in some ways it feels like we should be increasing our public awareness for, parents, adults who have interaction with children of what are the signs to look for? And hopefully that's something that you all can work with DC Health about. It may not change things, but it might help people who frankly might be in denial that, no, not my child, but it could also very well be your child as well. And let's try to get them connected to services as best as we can. Okay. Adult SUD in FY25, $150,000 in opioid settlement funds were allocated for a feasibility study for a behavioral health urgent care model. Do you have a status update on this study? Hopefully it's completed or underway or?
No, the study, we just allocated the dollars for the study to be done, if we're talking about the same thing.
Well, it's that you did it in FY25. So when you say you just allocated it, when?
Well, I may be mistaken. I'll have to follow up.
Okay,
We
it was announced in summer of 2025. So who got the study is a question, and what is the progress on it? Okay. In your pre-hearing responses, you all stated that nearly $1 million in opioid settlement funds were awarded to support contingency management. Now, my understanding is that the implementation of this initiative was delayed while DBH requested additional information from the grantees. What's the status of this award?
I can begin with that. Contingency management is an operant conditioning process that's used to address substance use disorders. And so if you think about it, from a behavioral perspective, that's what it is. There are multiple types of contingency management strategies that are out there that are currently being used within the field. And so as we talk to our members of the opioid committee and others, they asked that we really look at all of the models and evaluate which we thought might best meet the needs of Washingtonians. And so that was a part of that whole process. It's like, there's one in Florida where they use cell phones and what's called recovery capital as a part of the process. And there are other models. And so that was the
Okay.
reason. Okay.
I'm not questioning the use. I'm just asking, you selected a
Yes.
grantee, you delayed it. Now,
Right.
what's the status? That was my
We
question.
just recently
We
awarded
just
that,
recently awarded. Mhm.
that, the dollars to execute that program
Okay, when you say recently,
last month, within the last month.
within the last month. Okay, so we don't have well, are you still in the process of requesting more information from the grantee, or
No,
has that
that's-
process
that-
resolved?
They're
That
done.
process is resolved. The award's been made. That's what the delay was about. It's
Oh.
done. They're executing. They're about to execute now.
Okay, all right. We'll follow up on that. Adult inpatient. So you all reported that 282 adults were readmitted 2 or more times in fiscal year 25, which is higher than prior years. How are we identifying the individuals at high risk of repeat hospitalization, and what are the targeted interventions?
Yeah.
I think hospitalization. So, yep.
I think we very much, both on the psychiatric as well as behavioral health side, like in the SUD arena, when somebody's at the highest level of care, inpatient for some time, we make sure that we have staff following those patients in terms of their outpatient follow-up plan, and that they're able to connect. And if there are problems, we assist in that. So I think our role is secondary to the provider having a responsibility to hand off that consumer to another outpatient provider. But when the ball's dropped, we make sure we get involved and try to resolve it.
Okay. So we're definitely dropped, because also in your data, fewer than 40 individuals were actually connected to a core service agency within 5 days of discharge. So if I've got nearly 300 people who are in and out, in and out, in and out, and less than 40 of them, we've actually connected to a CSA, then yeah, so there's a disconnect here that is occurring. I guess I'm trying to figure out amongst the various agencies who's responsible here. And I don't know, let's say amongst the various agencies, but also I think perhaps some of these individuals are already enrolled in a Medicaid MCO. So somebody is supposed to be doing some level of care coordination and care management. Does DBH have the ability to have communications with those MCOs of like, hey, we're seeing Johnny been in and out 6 times. What are you guys doing, MCO, who we pay a lot of money to make sure that we're doing the right part? Because I'm not putting it all on you when I know we're paying somebody else who is supposed to be doing this in coordination with you. But as an oversight entity, are you asking these questions?
So the answer is yes to that. In particular for those patients, adult patients who are complex cases. So I lead the CIT meetings.
Okay.
And so CIT meetings occur.
Tell me what CIT stands for.
Community Integrated Treatment. I believe that's right.
Yeah.
Right.
We're on a new kick in the Committee on Health. We're going to stop using acronyms. We're going to explain to people what we mean, because nobody understands it. So.
That's very true. There's so many acronyms that we do. But this particular team is one that looks at the complex cases for those particular adults who have had those various situations that you're talking about. Readmissions, the ones who are struggling once they get out of the hospital, those who are struggling with CSAs. So this particular team, we meet twice a month. And so we have part of the Care Access Innovation team, which includes the ACT director, includes myself, also the deputy director, chief clinical services. And then we invite all the external stakeholders who are participating in the care for those particular consumers.
Including MCOs.
And yes, I mean, anyone's invited, yes. Rarely do we see MCOs, but if they want to be involved, we'll reach out to them, yeah.
All right. I mean, one of the MCO sort of markers, indications, et cetera, has been around hospital readmission. And this feels very high. I mean, it's certainly higher than we've had in past years. And so I think it's something that we need to drill down a little bit more on. And I'm happy to talk to Department of Healthcare Finance about that. It's less about the money. It's more about
Care coordination.
the care coordination piece.
And I should also say too, that it really, we got to talk about the type of patients who are seeing this readmission. So there's some patients who are not coming across our radar because they're not as complex. So they may have some people who are going back and forth, but they're not presenting to us because sometimes they may have had a suicidal attempt or something like that we may not be even aware of. So I hear what you're saying. And I wish we had a better way where we can receive that information to make sure we have done our job to make sure that we outreach to those particular persons who, we extend ourselves. We're there every, every twice a month to make sure that we have those type of meetings. But unfortunately, there are people who slip through those cracks.
Okay. We're going to talk really briefly about the stabilization center. Okay. We heard witness testimony on Monday. That was deeply troubling from a peer recovery specialist who works at the stabilization center. And I'm inclined to believe her because she worked an all-night shift and then sat there for multiple hours waiting for the opportunity to provide her testimony. And it was disheartening because the stabilization center had been a very bright spot. But she raised some serious concerns around staffing shortages and other things. So let me just start with the first question. Why did we, district government, pull back on the security that we were providing for the stabilization center? Was that always part of the agreement or did something else happen?
Can I start with that?
Yeah, you can. The other thing that I want to just kind of level set, and that is that I also met with her. And along with some other members of our team to discern what was happening at the stabilization center. And as a result of those efforts, they are on a corrective action plan.
Okay.
And so we have identified the issues that she stated, as well as other issues, and we are closely monitoring that. And I have tasked Dr. Moise and his team with following up on every single one of those issues. And we can report back to you on where we are, because we do have a report in terms of what kind of progress we've made. Because as you said, it is a needed service, a bright spot, and we don't want to make sure that quality care is not offered.
So you had met with her prior to her testifying? So you had met with her prior to her testifying?
Yes.
So how long has the stabilization center been?
It wasn't very long of a gap, weeks, I'm saying.
Just to fill in.
Yes.
Just to fill in real quickly. This individual had honest and legitimate, appropriate concerns.
Okay.
She reached out she connected with me in late October. Dr. Bazran and I and our team brought her to DBH for a hearing to listen to her concerns on November 3rd. We immediately reached out to CBI, the provider, about these concerns. They had to do with health and safety to some extent, like laundry and cleanliness and stuff.
Yep.
Staffing levels, supervision, training, coordination of care, and all of that. And we immediately did 2 site visits and put them on a corrective action plan. They've given us a very detailed corrective action plan that they're meeting right now.
Okay.
And we're following their progress, and we feel like we're going in the right direction.
Okay.
Regarding the issue of security,
Yes.
it's not security or not security. That provider uses a model from a therapeutic milieu perspective where they don't typically use armed guards, or security officers, if you will, in their settings, and train their staff to do de-escalation and manage crises and situations like that.
A year ago, when I was at the stabilization center, security was there. So that's why I'm asking, what was the plan? Was this a planned transition?
Yeah, that was a
Yes.
planned transition because it didn't fit with their model, and now we're seeing the need to reconsider that, to put it bluntly.
Okay, Councilmember Nadeau asked some questions about the second stabilization center. You kind of sort of mentioned it in passing, Dr. Bazaran, that it will be a delayed opening. I heard.
Yes,
Did I hear that?
yes, well, we have received some information that there is a potential delay in the opening. We were,
It's construction delay.
Construction.
in terms of the construction,
Okay.
process, yeah.
In terms of the operator for the second stabilization center, is that going to be an RFP?
Yes, it will be an RFA.
Or RFA.
And it will be, advertised. And we will, entertain and evaluate the applications.
Okay.
And we are aware that there are, providers with experience who are interested.
Okay. Give me just a second. I'm trying to pick and choose. Okay, Dr. Bazaran, there were several individuals who testified on Monday about the early intervention program, Healthy Futures. Center owners or staff who had lots of high praise for that program. And I think that anything that we can do around early intervention is helpful, especially helpful to families, helpful to staff, but also helpful to young people who in that 0 to 3 space, it's already chaotic to be a 3-year-old, and then you add, other things on top of it. The program is funded for 101 sites currently. Prior budgets had contemplated an expansion to 138 sites because we have a lot more eligible centers than we do providing service right now. Is the main barrier for expansion staff availability, or is it funding?
Both, yeah. Currently, right now, I think we had in our pre-hearing testimony, there's 17 consultants, we call them, in those roles. And so there's 2, in addition to that, there's 2 licensed clinicians who provide some treatment also for the younger children. And so those consultants are spread across 4 to 6 centers a week. They go to 4 different places. So they're spread pretty thin.
Yeah.
And so it would be FTEs to be able to go into more centers, but to have the FTEs, obviously, we need funding.
Okay. Is it, but you call them consultants, so are they contractors?
No, we just call them early childhood consultants. They're
Okay, so they are actual.
Their staff.
They're staff and they're licensed clinicians, but a variety, they're not all social workers. It's similar to kind of what we do with school-based
Okay.
mental health backgrounds.
Okay, so we have 2 licensed clinicians and then 17 consultants. Okay, in that group. All right. Hang on. Okay, I have one follow-up about Access Helpline, although it's a little meaty, so bear with me. Okay, so on Monday, we had a public witness who described recent changes to the Access Helpline procedures related to how clients can change their core service agencies. As it was explained, the new process requires clients to obtain in-person acknowledgements from their current CSA and their new CSA before DBH will update their client linkage in the ICAMS system. I know I just said we can't do acronyms, but I don't know what ICAMS is. I'm just gonna, a system. So witnesses noted that ICAMS frequently reflects outdated or inaccurate CSA assignments, which can complicate this process. So can you walk me through, that's a little weird that, let's say I want to break up with my CSA, I have to go in person and get them to sign off on breaking up with them? Is that what we're requiring?
Yes. And let me, to the best of my ability,
Okay.
describe the process. And then kind of where the directions we would like to think about going moving forward.
Okay.
Right? The form is called the Consumer Choice Form.
Okay.
And it was instituted kind of as a result of the MCO carve-in not happening.
Okay.
ICAMS is our electronic health record. And previous to the carve-in not happening, providers were also in that system. And so they would request CSA transfers inside that system. Now providers aren't in it anymore.
Yeah.
So this consumer choice form was a short-term kind of solution to handling consumer transfers because we were supposed to carve in, and then carve in didn't happen. And so it's a legacy, kind of a legacy document that now has this added component of both the provider who is sending the consumer and the provider who is receiving the consumer needing to sign the form as an attempt to kind of address some of the fraud in the system and frankly, inducements of providers paying a consumer
Yeah, we heard
to say you belong to me,
Yeah.
right? So it was an attempt to kind of address that. But now, as we're moving forward, enrollments are actually now handled through Comagin as well.
Okay.
With, if I'm a provider and I have my consumer choice form that's signed, I submit that to Comagin to get my prior authorization for community support. That's kind of effectively not even authorization, certification that the consumer has enrolled with
Right.
that new agency. But we still have this legacy form.
So we need to figure out what to do with the legacy
Yeah,
form.
there's process that needs to happen that I'm circulating now a decision memo up to the director that she's not yet seen and has heard about but hasn't seen yet to try to clean this up.
Okay.
So we resolve this issue with this legacy form and this new process that we actually have through Comagin that should verify who the actual provider of record is.
Okay.
So I'm hoping we can do that fairly quickly and resolve some of what you were hearing then around this. Yes, that's a little difficult to manage if I've got to get these signatures, and it's a little bit kind of conflated roles, if you will,
Okay.
right? Enrollment is enrollment, and fraud, waste, and abuse is fraud, waste, and abuse, and it's a little bit mixed up in that one form.
That was a great answer. It was very informative. I learned something, and thank you. You answered the question. Are you good? Yeah, but she's good too. Let me ask, in terms of the relationship with Comagin, if you all were to add recovery support in terms of their line, how much more will Comagin charge us?
DHCF manages that contract.
Okay.
And they would have to negotiate the rate.
Okay. All right. Dr. Bazaran, is there anything you want to share that we have not talked about?
No, but I would like, to thank you for your ongoing support and interest, and we are moving forward.
Great. Well, I would tell you, you had 5 council members here today, which I think speaks to the importance of the work that the Department of Behavioral Health does, both committee members and non-committee members. So that's how far-reaching it is across the city. So I first want to thank your staff and the work that you all are doing each and every day on behalf of district residents, the ones who are frontline, the ones who are in community, the ones who are doing the behind-the-scenes work. I know that public service these days on the federal side is often demonized and not in vogue, but I know that people are working very hard. And just because we were asking oversight questions on our side, it's not to further push on that, but it is to make sure, are we doing it in the most effective and efficient manner possible, again, on behalf of the district residents for whom we serve. So I want to thank you for your team being here today, providing testimony and information to the committee. If we have some additional questions, we'll certainly follow up with you all. For the public who is watching, who's like, oh, you didn't ask my specific, question, need, hope, desire. We do have regular conversations with the Department of Behavioral Health, and we also have a number of issue-specific roundtables that are coming up in March on some of these issues where we can go into in-depth even further on some things like CRFs and youth crisis response. So we'll certainly get there. So although the hearing today was only for government witnesses, anyone who would like to submit testimony for the record, you weren't able to do so on Monday, You have until Wednesday, February 18th at 5 p.m. to do so. You may submit your written testimony on the council's website at dccouncil.gov/hearings. As for this committee, our next performance oversight hearing will be held on the Food Policy Council, the Board of Pharmacy, the Board of Dentistry, and the Board of Optometry on Wednesday, February 11th at 9:30 a.m. The time is 1:33 p.m. And this hearing is adjourned. Thank you, everyone.
Thank you.